Now we are going to discuss important topics of pediatric surgery. First, we are going to discuss tracheoesophageal fistula. So what happens in tracheoesophageal fistula? There is abnormal communication between trachea and esophagus, and sometimes it is associated with esophageal atresia. Classification of tracheoesophageal fistula is very important. It is frequently asked. See the types. It is divided into 5 types: A, B, C, D, E. What happens in type A? You can see it is pure esophageal atresia. So there is no tracheoesophageal fistula, there is only pure esophageal atresia. If you see type B, in type B there is esophageal atresia with proximal fistula. Here you can see there is proximal fistula. And in type C there is distal fistula. Esophageal atresia with distal tracheoesophageal fistula. In type D there is both proximal as well as distal tracheoesophageal fistula, and in type E there is no atresia, there is only fistula. No atresia, there is only fistula. And if you see the shape, it looks like H. So this is also known as H-shaped fistula. This is also known as H-shaped fistula. These are 5 types. First question which is asked, that out of these 5, which one is most common? It's the type C, which is most common. In exam, they don't mention type C, they mention which of the following is most common type, and it is esophageal atresia with distal tracheoesophageal fistula, most common. And which one is the least common type? It's the type D, in which there is fistula involving both proximal and distal segment. So esophageal atresia with both proximal and distal tracheoesophageal fistula, it's the least common type. Okay, see the clinical features, very easy to understand. If a patient is having pure atresia, in that case what happens? There is drooling of saliva. Saliva will not go beyond this point, so what will happen? There will be drooling of saliva from the corner of mouth, and if oral feed is given to the baby, what will happen? There is regurgitation. So drooling of saliva and regurgitation, these are seen in patients who are having esophageal atresia. If a patient is having tracheoesophageal fistula, see here, this patient is having tracheoesophageal fistula. So what will happen? Whatever the food is being given, saliva, all these things are going to enter into trachea, and patient will be having choking, coughing, cyanosis, dyspnea. So esophageal atresia, drooling of saliva, regurgitation of food. Tracheoesophageal fistula, there is choking, coughing, cyanosis, dyspnea because of aspiration of saliva or food stuff. Clear? Clinical manifestation. Now, how we are going to make the diagnosis? Again, it's very easy. Try to insert Ryle's tube. If we are inserting Ryle's tube, what will happen? In pure esophageal atresia, it will coil in the esophagus. You are not able to insert Ryle's tube into stomach. So in esophageal atresia, coiling of Ryle's tube will occur in esophagus. You are not able to insert it into stomach. Second situation, imagine a patient is having tracheoesophageal fistula. In tracheoesophageal fistula, what will happen? There is presence of gas. Okay. In pure esophageal atresia, you will not find any gas on X-ray. But if there is tracheoesophageal fistula, there is presence of gas. Right? There was one question in latest exam, that what is the investigation of choice for diagnosis of H-shaped fistula, or how we can confirm the diagnosis of H-shaped fistula. So if you see this H-shaped fistula, here we perform tracheobronchoscopy, and what we perform to assess esophagus endoscopy. What is the investigation performed to confirm the diagnosis of H-shaped fistula? Tracheobronchoscopy plus endoscopy. Clear? There is one association of tracheoesophageal fistula, and that anomalies are known as Vacteral anomalies. So in TF, Vacteral anomalies are associated. What are the components? V, that is vertebral body segmentation defects. A, that is anal atresia. C, cardiovascular abnormalities. TE, that is tracheoesophageal fistula. R, renal abnormalities. And what's the problem here? Unilateral renal agenesis. There is unilateral renal agenesis, and there are limb anomalies. What's the anomaly? There is radial ray hypoplasia. What's the problem? There is radial ray hypoplasia. Okay, out of this vectoral anomaly, which one is the most common association? Frequently asked question, and it's the cardiovascular abnormalities are the most commonly associated abnormalities. What are the abnormalities seen here? There is VSD, ventricular septal defect, and PDA, patent ductus arteriosus. Out of VSD and PDA, which one is most common? Is the VSD, which is most common. So in vectoral anomalies, most common abnormalities is cardiovascular. In cardiovascular abnormalities, most common abnormality is ventricular septal defect. Biliary atresia is the most common indication for pediatric liver transplantation. Why? Because in biliary atresia, there is progressive obliteration of both intrahepatic bile duct as well as extrahepatic bile duct. Progressive obliteration of both intrahepatic bile duct and extrahepatic bile duct, and this is the most common indication for pediatric liver transplantation. Here you have to remember the classification. Name of classification is Kasai classification. And what is the treatment of choice? It is Kasai procedure. So name of classification, Kasai classification. Name of procedure, Kasai procedure. Have a look. According to Kasai classification, it is divided into 4 types. Type 1, type 2A, 2B and 3. What happens in type 1? You can see that there is atresia involving CBD. It means CBD is obliterated with patent common hepatic duct and cystic duct. CBD is obliterated. In type 2A, you can see that there is obliteration of common hepatic duct. So there is common hepatic duct atresia with patent cystic duct and CBD. If you see this type 2B, in this there is obliterated CBD, obliterated common hepatic duct and cystic duct. So in type 2B, there is obliterated common hepatic duct, cystic duct and CBD. And the most common type is type 3. In type 3, there is atresia of CBD, cystic duct, common hepatic duct up to porta hepatis. This is porta hepatis. Clear? So in type 3, atresia of CBD, cystic duct and CHD, common hepatic duct, occurs till porta hepatis. Out of these, type 3 is most common. So what you noticed, that there is obstruction because of obliteration or atresia of some part of bile duct, and because of this what will happen? There is obstruction, and that's why these patients are going to develop obstructive jaundice. So certain patients have jaundice at the time of birth, and some patients are going to develop jaundice just after birth. Okay, there will be signs and symptoms related to jaundice. There will be complications if there is delay in diagnosis or treatment, like portal hypertension and cirrhosis. What's the gold standard investigation for diagnosis of biliary atresia? It is intraoperative, or also known as peroperative cholangiogram. Okay, this is also known as, since we are going to inject the dye via gallbladder, it is also known as cholecystocholangiogram. So other name of this is cholecystocholangiogram. Cholecystocholangiogram. Right? You have to remember, this is the gold standard investigation. There is question related to hepatobiliary scintigraphy. What's the finding on hepatobiliary scintigraphy? Normally, what's the problem? See here, this is the gallbladder, this is the bile duct. So in biliary atresia, there is obstruction, and if the obstruction is there, what will happen? There will be uptake of radiotracer to the liver. The uptake of radiotracer into the liver without any flow or excretion into intestine. Why? Because there is atresia. So if you perform hepatobiliary scintigraphy, see, after 30 minutes you can see uptake is there in the liver without any flow into intestine. After 3 hours also no flow into intestine, and after 24 hours also you can see there is no flow into intestine. So there is radiotracer uptake into the liver without any excretion into the intestine. Characteristic feature of what? Biliary atresia. Okay, and what is the treatment of choice? It is Kasai procedure, also known as hepatoportoenterostomy. Here you can see this is Kasai procedure, also known as hepatoportoenterostomy, also known as Kasai hepatoportoenterostomy. Okay, so here we perform the anastomosis between porta hepatis and small intestine. Clear? Porta hepatis and small intestine after excision of bile duct. This is one treatment, and we discussed that in biliary atresia we perform liver transplantation also. Biliary atresia is the most common indication for pediatric liver transplantation. What is the most common site of intestinal atresia? It is duodenum. It is duodenum. There is another question which is asked in relation to atresia. Most common cause of neonatal intestinal obstruction, and that's duodenal atresia. Duodenal atresia. This is the most common cause of neonatal intestinal obstruction. Neonatal intestinal obstruction. These are two one-liner questions which are asked. After that, the questions are asked in relation to the classification of jejuno-ileal atresia. Here you can see 5 types of jejuno-ileal atresia. First, see what is type 1. In type 1, you are going to notice that there is membranous atresia with intact bowel mesentery. What happens in type 2? Here you can see the bowel ends are separated by a fibrous cord. If you see type 3A, there is V-shaped defect in the mesentery. So the bowel ends are separated with the V-shaped defect in the mesentery. Type 3B, this is commonly asked in exam. Why? Because it is also known as apple peel atresia. Can you see it looks like apple peel, or Christmas tree atresia? Appearance is like apple peel or Christmas tree. So type 3B is apple peel or Christmas tree atresia. This is image based question which was asked many times in exams. And what is type 4? Here you can see there are multiple atresia, and if you see the appearance, it looks like string of sausages. Looks like string of sausages. So these are the types of jejuno-ileal atresia. In these images, what you can see that there is external presacral mass with minimal intrapelvic presacral component. So mainly there is external presacral mass. And what's the name of this condition? It is sacrococcygeal teratoma. So one question which is asked in relation that what is the most common site of sacrococcygeal teratoma? It's self-explanatory. It's the sacrococcygeal region. So the most common site is sacrococcygeal region, in which you are going to see external presacral mass mainly. Generally it is more common in females. It is benign. Neonatal sacrococcygeal teratomas are benign. But what happens? The risk of malignancy increases with age. In PGI Chandigarh, there was one question that sacrococcygeal teratoma is thought to be a derivative of primitive streak. This was a question. It's a derivative of primitive streak. Clear? How we make the diagnosis of sacrococcygeal teratoma? So just by looking at the tumor, what? It's a clinical diagnosis. You can see that there is external presacral mass with minimal intrapelvic presacral component. If you want to see the intrapelvic component, we have to perform MRI. CT or MRI is done to assess the intrapelvic component. What is the treatment? We have to go for complete surgical excision with resection of coccyx. So what's done is the complete surgical excision. Complete surgical excision with resection of coccyx. Resection or excision of coccyx is mandatory. Why? If it's left, it is going to cause recurrence. So the treatment is complete surgical excision with resection of coccyx. So this is how we manage sacrococcygeal teratoma, and this is all about pediatric surgery. Now we are going to discuss trauma. First, we are going to discuss the triage. What is the literal meaning of triage? The literal meaning of triage is to sort. Generally, triage is used in mass casualties like bomb blast, like earthquake. In exam, the question is specifically asked related to triage tags. These are the triage tags. Here, red color signifies immediate care. Red color, it is going to signify immediate care. Clear? It means this patient is most critically injured. So red is for most critically injured where immediate care is required. Yellow is for less critically injured patients and it signifies delayed care. It means these patients require in-hospital treatment. Green color, it's for ambulatory patients, the patients who are not having any limb or life-threatening injury. So this is for ambulatory patients. It's for ambulatory patients. And the black color is for dead or moribund patient. It means here expectant treatment is done. Means nothing active is done in the patients who are having black tag. So black, this is for dead or moribund patients. It's for dead or moribund patient, and black color signifies expectant treatment where nothing active is done. There are three terms. One is ATLS, second is ACLS, and third is BLS. ATLS, second is ACLS, and third is BLS. The full form: ATLS is Advanced Trauma Life Support, ACLS is Advanced Cardiovascular Life Support, and BLS is Basic Life Support. The question which is asked, that which protocol is followed in ATLS, it is ABC or CAB. So if you see ATLS, here we follow ABCDE. Okay, it's airway, breathing, circulation, disability, exposure with environmental control. ABCDE. But in ACLS and BLS, we are going to follow CAB. CAB, that is circulation followed by airway followed by breathing. So read the question carefully what is mentioned in exam. According to ATLS protocol, it is ABCDE. Okay, we are going to discuss the ATLS protocol of trauma, and in ATLS protocol there is primary survey and secondary survey. First we are going to discuss primary survey. Primary survey is aimed at simultaneously detecting and treating the life-threatening injury. Detecting and treating life-threatening injury. What is the sequence which is followed in primary survey? A. So it is airway maintenance with cervical spine. B. Breathing, and it includes ventilation and oxygenation. C is circulation with hemorrhage control. D, that is disability. In this we perform brief neurological examination. And E, here we expose the patient. So this is exposure with environmental control to prevent hypothermia. 5 components: A, B, C, D, E. One by one we are going to discuss. First, airway maintenance with cervical spine protection. Suppose in the option both are mentioned, airway as well as cervical spine protection, which should be given the first priority? The first priority should be given to cervical spine protection. Okay, so in A, it is cervical spine protection followed by airway. In all trauma patients, we have to suspect the cervical spine injury. So first step, cervical spine protection followed by airway maintenance. After cervical spine protection, we have to go for airway maintenance. Any patient who is having compromised airway, what is the stepwise progression? So first we have to clear the airway by suctioning the secretions if it's there in the mouth or blood. So it's clearing of airway by suctioning of secretions or blood if it's present. Then we go for chin lift and jaw thrust, and then we insert the oropharyngeal or nasopharyngeal airway. What is the definitive airway of choice? Definitive airway of choice in trauma patient. So this is oral endotracheal intubation with cuffed ET tube. This is oral endotracheal intubation with cuffed ET tube. Okay, in all trauma patients, this is the definitive airway of choice, oral endotracheal intubation with cuffed ET tube. Second question, which was asked many times in AIIMS, that patients who are having severe maxillofacial trauma, in such patients, what is the emergency airway of choice and what is the definitive airway of choice? So, emergency airway of choice is needle cricothyroidotomy. It's needle cricothyroidotomy. Okay. And what is the definitive airway of choice? You must be knowing, we perform a tracheostomy. So it is tracheostomy. Three questions. First, definitive airway of choice in most of the trauma patients, oral endotracheal intubation with cuffed ET tube. In severe maxillofacial injuries, emergency airway of choice, needle cricothyroidotomy. Definitive airway of choice is tracheostomy. The second step is breathing, which includes oxygenation and ventilation. So here we are going to assess breathing, rate and depth of respiration, and we are going to assess the oxygen saturation. First step was airway maintenance. So if airway is maintained, despite of that patient is having dyspnea, tachypnea, saturation is less. In all these cases, we have to look for what? Causes of ventilation problems. And what are the causes of ventilation problems? It can be because of tension pneumothorax, massive hemothorax or massive pulmonary contusion. So these patients might be having ventilation problems. If despite of airway maintenance, there is dyspnea, tachypnea, saturation is less, tension pneumothorax, hemothorax, massive pulmonary contusion. So if patient is having tension pneumothorax or patient is having hemothorax, how you manage? Yes, what is the treatment of choice? We insert chest tube. So it is managed by ICD insertion. Okay. Third problem, that certain patients are having massive pulmonary contusion. So in such patients, we go for aggressive mechanical ventilation. So if patient is having massive pulmonary contusion, in such patient, we go for aggressive mechanical ventilation. Mechanical ventilation. So these are the components of B, breathing, which includes ventilation and oxygenation. C is circulation with hemorrhage control. So in such patients, we have to assess the circulation. Here our primary goal is to rule out shock. Why? What is the most common cause of shock in patients of trauma? It's the bleeding or hemorrhage. So what is the most common type of shock in patients of trauma? It's hypovolemic shock. So main thing, we have to look for signs and symptoms of shock. And what is the cause? It's because of bleeding. So which type patient is having? Hypovolemic shock. Okay. In evaluation, we have to look for the vitals. We assess vitals, pulse rate and BP. If pulse rate is more than 100 per minute, systolic blood pressure is less than 100 mmHg, it is suggestive of unstable vitals. What? Pulse rate. If it is more than 100 per minute, and systolic blood pressure, if it is less than 100 mmHg, remember the value 100. It's unstable. It means these are the patients who are having shock and we have to manage the shock. How you manage any patient of shock? First, put 2 large bore IV cannula. So preferably green cannula, which is of 18 gauge, we are going to insert. After inserting the cannula, we have to take blood sample and send the blood sample for cross match. Put 2 large bore IV cannula, send blood for cross match, and we have to give the crystalloids. Initially, just after insertion of cannula, it was mentioned that 1 to 2 liters of warm isotonic crystalloids should be given. This is according to the older data. According to ATLS modification 2018, what? Rather than 1 to 2 liter, nowadays we just give 1 liter. How much? 1 liter of warm isotonic crystalloids are given in adults. In adults and in children, it's 20 ml per kg of body weight. warm isotonic crystalloids in children. So you have to remember, because this question was asked in one of the latest AIIMS exam. In adults, 1 liter of warm isotonic crystalloids are given, and in children it's 20 ml per kg of warm isotonic crystalloids are given. Any patient who is having shock, it means there is blood loss. What is the site of blood loss? On the floor or foremoor. On the floor means external blood loss at the site of accident, or 4 sites in the body. So the 5 major locations of blood loss are external blood loss at the site of accident, in chest because of hemothorax, in abdomen if the patient is having hemoperitoneum, in retroperitoneum, or blood loss because of multiple long bone fractures. So these are the 5 major locations of blood loss. How we are going to evaluate? So which investigations are done? For chest, we have to perform chest X-ray, PA view. For abdomen, we perform FAST, and for pelvic fractures, we perform X-ray pelvis, X-ray pelvis, AP view. So question, what are the investigations done? We perform chest X-ray PA view for assessment of chest. We perform FAST for evaluation of abdomen, and we perform X-ray pelvis AP view to look for any fracture in the pelvis, right? The question which is asked, that what are the 2 most important X-rays in trauma patients? 2 most important X-rays in trauma patients are chest X-ray PA view and X-ray pelvis AP view. Chest X-ray PA view will tell you about hemothorax, pneumothorax, and it will tell you about perforation peritonitis also. X-ray pelvis will tell you about pelvic fracture. Clear? So 2 most important X-rays in trauma patients: chest X-ray PA view, X-ray pelvis AP view. In AIIMS, there was one question, that which of the following investigation is not performed in primary survey? CT scan is not performed. We perform FAST, we perform chest X-ray, X-ray pelvis. CT scan is not the part of primary survey. Imagine we are giving the fluid. Fluid transfusion is being given to the patient, but patient is having ongoing signs of shock. In non-responding patients with ongoing signs of shock, we have to manage ongoing bleeding. So if patient is having signs of ongoing shock, we have to manage ongoing bleeding, and we have to start blood transfusion. What you have to start? Blood transfusion if patient is not responding to fluid administration. This question is asked almost every year, that according to trauma transfusion protocol, packed cell, plasma and platelets are given in which ratio? According to trauma transfusion protocol. Trauma transfusion protocol, we have to give packed cells, plasma and platelets in the ratio of 1:1:1. You have to remember this ratio. Packed cells, plasma, platelets are given in the ratio of 1:1:1. We discussed this question in burns also, that what is the best clinical indicator of tissue perfusion in burn patient, or best clinical indicator of tissue perfusion in trauma patients? Answer is same, it is urine output. And how much should be the minimum urine output? 1 ml per minute in adults, 0.5 to 1 ml per minute in children. Okay. See the twist in the question. Best indicator to determine fluid requirement. So best indicator to determine fluid requirement is CVP. Is the central venous pressure, CVP. These are 2 important one-liners. The 4th step is disability, in which we perform brief neurological examination. Here we are going to assess Glasgow Coma Scale, GCS, and we assess the pupils. So what we are going to look in the pupils? Size, reaction and equality. We look for size, reaction and equality. Okay. In 4th step, that is disability. Lots and lots of questions are asked about GCS. Every year there is one question in which you are supposed to calculate the GCS. There are certain modifications in GCS, and this modification was done in 2014. So see the modified GCS. There are three components of GCS. First is eye opening, second is verbal response, and third is best motor response. The first question which is asked, that in GCS the best predictor of outcome, which one is the best predictor of outcome? And the best predictor of outcome is what? Best motor response. So how to remember? Best predictor of outcome is best motor response. Sometimes in the question they don't mention the word best, they only mention motor response. So what you have to choose? Best motor response. Now see the details. In cases of spontaneous eye opening, how much is the score? It is 4. If eye opening is to loud voice, it is 3. Now let me tell you the change in 2014. Initially, it was to loud voice, but in 2014, speech is added. So here eye opening to speech. If it is to pain, the score is 2. This is according to previous GCS. According to 2014, at the place of pain, pressure is mentioned. So eye opening to pressure, and here the score is 2. And if there is no response, how much score is given? It's 1. So spontaneous 4, to speech it's 3, to pressure it's 2, and no response it's 1. The verbal response. If patient is oriented, score is 5. Patient is confused, score is 4. If patient is speaking inappropriate words, initially inappropriate word was mentioned in GCS 2014, this inappropriate term is removed. So only words is mentioned. The score is 3. Previously, incomprehensible sound was mentioned. In 2014, the term incomprehensible is removed. So only sounds are there. Score is 2. And if there is no response, it's 1. Patient is oriented. Score is 5. Confused. 4. Patient is speaking words. 3. Producing some sounds like a, e, a, o. Then it's 2. And if there is no response, the score is 1. If patient obey commands, the score is 6. Patient is going to localize the pain. How much is the score? It's 5. If there is normal flexion to pain or there is withdrawal to pain, the score is 4. If there is abnormal flexion, score is 3. And if there is extension, what is the posture of patient? Extension, then it's 2. And if there is no response, how much is the score? It's 1. Clear? So this is eye opening, verbal response, and best motor response. It is easy to remember this eye opening. There is mnemonic to remember the verbal response and best motor response. So how to remember the verbal response? See, it's one confused word sounds nowhere. Mnemonic is one confused word sounds nowhere. So one means oriented, confused means confused. Words, it means inappropriate words or words. Sounds, nowhere means no response. Okay, so here you can see the score. Oriented 5, confused 4, words 3, sounds 2, nowhere means no response 1. So this is for verbal response. The mnemonic for best motor response is obey localities with flexion and extension. Obey means obeying commands, score is 6. Localizes pain, here the score is 5. Withdrawal to pain, yes, that is normal flexion. Withdrawal to pain, this is 4. Abnormal flexion, the score is 3. And for extension posturing, score is 2. And if there is no response, the score is 1. So this is how you can remember the verbal response and best motor response. Okay. If we see the total score of GCS, the maximum score is E4, V5, M6. So how much is the maximum score? 15. And if you see the minimum score, it's E1, V1, M1. Okay, so the GCS score varies from 3 to 15. GCS score varies from 3 to 15. We discussed the best predictor of outcome is best motor response. According to GCS, we are going to divide head injuries into mild, moderate and severe. In cases of mild head injury, how much is the GCS score? It is 13 to 15. In cases of moderate head injury, the score is 9 to 12. And if patient is having severe head injury, here the score is less than equal to 8. Another problem, some patients are there in which we are not able to assess one parameter or one component. Imagine a patient who is having tracheostomy. Patient who is having tracheostomy, in these patients you cannot assess the verbal response. So any element or component which cannot be tested, we are going to add NT in front of that component. So if verbal response is non-testable, if the patient is having tracheostomy, we are going to write it like this, VNT. Initially, we used to assign score of 1 for non-testable components or elements, but nowadays additional score of 1 should not be assigned to non-testable components. Let's discuss with one example. Suppose a patient is having spontaneous eye opening. So how much is the E4? If patient is having tracheostomy, you cannot assess the verbal response, so it is VNT. And patient localizes pain, so what is the motor response? M5. So this is E4 VNT M5. This was the question which was asked 2 to 3 times in NIMS. Sometimes they ask you question and the options are given in this format, and sometimes scoring is given. So what should be the score? So here you should not assign one score for VNT. So total score will be 9, right? So it is E4 VNT M5, but the total score is 9, right? So if a component or element is non-testable, no score should be given to that non-testable component, and NT should be mentioned in front of that particular component. In exposure and environmental control, we have to expose the patient. So what? Expose the patient. Okay, so all clothing of patient should be removed, but important point, we have to prevent hypothermia. To prevent hypothermia, we have to go for environmental control of temperature. So we use pre-warmed IV fluids, we use blowers, warm blankets for such patients. So these were the components of primary survey. Now let's discuss the secondary survey. In secondary survey, we have to obtain ample history either from the patient or the relative of patient. Okay, what you are going to obtain: A means history of allergies, M medications patient is taking, any significant past illness whether patient is pregnant or not, last meal when patient had the last meal, and events related to injury. So you have to obtain ample history. Detailed systemic examination from head to toe. After obtaining ample history, we have to go for detailed systemic examination from head to toe in sequence. So what's the sequence of secondary survey? First step is examination of head and face. And in examination of head and face, what we have to rule out? Fracture or laceration. So rule out fracture or laceration. Second step is examination of neck. And in this case, we have to rule out neck injuries. Neck injuries. Third step is examination of chest. In this, we are going to rule out the rib fracture. Fourth is abdomen. Is very, very important. You have to remember. In examination of abdomen, we have to look for any tenderness. So on examination, any tenderness is there. Any bruising means external sign of injury is there. During examination of abdomen only, or in this particular step only, we have to go for nasogastric insertion. So nasogastric tube insertion. Some patients who are having maxillofacial trauma, in these patients, or patients who are having facial trauma, in these patients, at the place of nasogastric insertion, we go for what? Orogastric insertion. So in abdominal examination, nasogastric insertion is done. If patient is having facial trauma, in those cases, we go for orogastric tube insertion. In this step only, we have to insert the Foley's catheter. But before inserting Foley's catheter, you have to check the meatus for the presence of blood. Evidence or presence of blood at meatus can be because of urethral injury. So if no blood is at meatus, in that case, Foley's catheterization. Foley's catheterization if there is no blood at meatus. Okay. Fifth step, very important. This is very important, asked frequently in exam. First, what's the other name of this step? It is also known as log roll. Examination of back, it is also known as log roll. Two questions are asked. First, ideally, how many people are required for examination of back? Ideally, 5 people are required. And minimum number of people required for examination of back, that's 4. Ideally, it's 5. Minimum number of people required for examination of back, that's 4. Extremities. In extremities, we have to rule out fracture. So we have to look for crepitus, deformity, any abnormal movement. And we have to perform the repeat neurological examination. So these are the 7 steps. Examination of head and face, neck, chest, abdomen, then back, extremities, and 7th step is repeat neurological examination. 3 trauma scoring systems which are asked in exam. First is revised trauma score. What are the components of revised trauma score? GCS, blood pressure, it's the systolic blood pressure, and third is respiratory rate. So it's GCS, blood pressure, respiratory rate, 3 components. How to remember? GB road. So the mnemonic is GB road. Okay, don't go to this road, don't go. So it's GB road, GCS, Glasgow Coma Scale, BP, which type of systolic, RR, respiratory rate. Trauma and injury severity score, in short it's known as TRIS. And how to remember? It is the injury severity score plus RAM. So components are injury severity score plus RAM. What do you mean by R? R means revised trauma score, A means age, M means mechanism, whether it's blunt or penetrating. Clear? So R, the components are, this is revised trauma score, A means age, M means mechanism, whether this is blunt, because of blunt, or because of penetrating trauma. So these are the components. After that, mangled extremity severity score, this is asked in surgery as well as in ortho. So in short, it is known as MES, mangled extremity severity score. And what are the 4 components? Energy, limb ischemia, shock, age. How to remember? The mnemonic is ELISA. ELISA. Okay. So energy, limb ischemia, shock, age. These are very important. Since mnemonic is there is no problem in remembering. Now we are going to discuss important topics of head injury. First, skull base fracture. Skull base fracture include anterior cranial fossa fracture, middle cranial fossa fracture, and posterior cranial fossa fracture. Overall, which one is most common? You can see anterior cranial fossa fracture is responsible for 70% cases. And if we see combined incidence of middle cranial fossa fracture, it's 25%, and posterior cranial fossa fracture, it is responsible for 5%. So most common, it's the anterior cranial fossa fracture, followed by middle cranial fossa fracture, followed by posterior cranial fossa fracture. Okay, one by one we are going to discuss the important thing. Anterior cranial fossa is mainly formed by which bone? Frontal bone. It's mainly formed by frontal bone. So if there is fracture of frontal bone, what will happen? There is frontal lobe contusion. Here you can see this middle cranial fossa is mainly formed by temporal bone. Okay, one part is sphenoid also, but it's mainly formed by temporal bone, and that's why in middle cranial fossa fracture, which contusion is seen is the temporal lobe contusion. Similarly, posterior cranial fossa is mainly formed by occipital bone. Occipital bone, and that's why it is associated with occipital lobe contusion. If we see specifically in frontal bone, there is fracture of cribriform plate, and if there is fracture of cribriform plate, these patients are having what? CSF rhinorrhea. What are the other important features of anterior cranial fossa fracture? Have a look. So we discussed overall its most common type of skull base fracture. It is associated with frontal lobe contusion. There is epistaxis. There is subconjunctival hematoma. Because of fracture of cribriform plate, there is CSF rhinorrhea. It is also associated with anosmia and periorbital hematoma. This periorbital hematoma is also known as raccoon eyes. So here you can see this is periorbital hematoma or periorbital ecchymosis known as raccoon eyes. So how to remember? The mnemonic is simple. It's frontal escape. So how to remember? The mnemonic is frontal escape. Okay. Frontal lobe contusion, epistaxis, subconjunctival hematoma, CSF rhinorrhea, anosmia and periorbital hematoma also known as raccoon eyes. In middle cranial fossa fracture, there is fracture of petrous part of temporal bone and this leads to dural laceration. And if there is dural laceration, what's the problem? CSF starts coming out. If tympanic membrane is ruptured, CSF is coming out. This is known as CSF otorrhea. It's known as CSF otorrhea if tympanic membrane is ruptured, and if tympanic membrane is intact, then CSF is coming out via nose. This is known as otorhinorrhea, also known as paradoxical rhinorrhea. Otorhinorrhea or paradoxical rhinorrhea if tympanic membrane is intact. We discussed that in middle cranial fossa fracture, there is fracture of petrous part of temporal bone. This fracture leads to dural laceration. Because of dural laceration, what happens? CSF is coming out via ear if tympanic membrane is ruptured. So this is known as CSF otorrhea. Patients who have intact tympanic membrane, in those cases CSF is coming out via nose. This is known as otorhinorrhea, also known as paradoxical rhinorrhea. So tympanic membrane is ruptured, it leads to CSF otorrhea, and if tympanic membrane is intact, it leads to rhinorrhea, that is known as otorhinorrhea, also known as paradoxical rhinorrhea. You know that in these patients there is post-auricular ecchymosis, that's known as Battle sign, and there is relation of 7th and 8th cranial nerve to the petrous part of temporal bone. So if it is fractured, there is injury to 7th and 8th cranial nerve. Since middle cranial fossa is mainly formed by temporal bone, it leads to temporal lobe contusion. What? Temporal lobe contusion. There are important image-based questions which are asked in relation to middle cranial fossa fracture. Have a look. So in this picture you can see there is post-auricular ecchymosis, that's known as Battle sign. This is the image-based question asked frequently. Battle sign, post-auricular ecchymosis or ecchymosis over mastoid process. Okay. Here you can see that the CSF is coming out via ear because tympanic membrane is ruptured. This is CSF otorrhea, and sometimes the blood is collected beneath tympanic membrane. This is known as hemotympanum. So there is Battle sign, there is CSF otorrhea and hemotympanum in middle cranial fossa fracture. Now have a look of posterior cranial fossa fracture. We discussed that posterior cranial fossa is formed by occipital bone. So fracture leads to occipital lobe contusion, and whenever there is occipital lobe contusion, obviously it will lead to visual disturbances. In occipital bone fracture, there is 6th cranial nerve injury. You can see that there is a foramen in relation to occipital bone. This is known as jugular foramen, and via this jugular foramen 3 nerves are coming out: 9th, 10th and 11th. So 9th, 10th, 11th nerves are passing via jugular foramen because of fracture of occipital bone. What's the problem? There is jugular foramen syndrome. Why? Posterior part of jugular foramen is formed by occipital bone. So whenever there is fracture, there is involvement of 9th, 10th, 11th cranial nerve. So what? There is involvement of 9th, 10th, 11th cranial nerve. This is known as jugular foramen syndrome, also known as Wernicke syndrome. Also known as Wernicke syndrome. And in occipital bone fracture, there is increased risk of basilar artery injury. Okay, so what are the characteristic features? Occipital lobe contusion. There are visual disturbances, 6th cranial nerve injury, jugular foramen syndrome, and increased risk of basilar artery injury. So these are important points related to skull base fracture. Here it kar dena. So these are important points related to skull base fracture. One question which is asked almost every year, that's EDH and SDH. Sometimes it is asked in the form of image based question, NCCT is given. See the differences. If you see EDH, that is epidural or extradural hematoma. So it is extradural. Blood is collected between skull and dura. So here you can see the blood. This blood is collected between skull and dura. This is dura and this is the skull. If you see the subdural hematoma, subdural, here the blood is collected between dura and arachnoid. This is dura and this is arachnoid. So in subdural, blood is collected between dura and arachnoid. See the cause. Even after trivial trauma to the weakest part of skull, that is pterion, it's a part of temporal bone, pterion, weakest point. Even the trivial trauma can lead to injury. Because of this pterion injury or fracture of this temporal bone, there is injury of middle meningeal artery. And because of injury of middle meningeal artery, there is bleeding. So what kind of bleeding occurs in extradural hematoma? That is arterial. What happens in SDH? In SDH, significant trauma is required and it is generally seen in elderly. Because of significant trauma, there is injury of bridging veins, also known as cortical veins. So injury of bridging veins or cortical veins. So what kind of bleeding is there? Here, there is venous bleeding. There is venous bleeding. In extradural hematoma, this is arterial bleeding from middle meningeal artery. Dura is peeled off in extradural hematoma, but dura is intact, attached to skull in STH, that's subdural hematoma. This extradural hematoma, it's not going to cross the suture line, but this subdural hematoma, it can cross the suture line. There is an important point associated with EDH, that lucid interval is positive. In extradural hematoma, lucid interval is positive. Some definitions are asked in relation to SDH, that what is acute SDH, what is subacute SDH, what is chronic SDH. Acute SDH, so whenever the duration of SDH is up to 3 days, duration up to 3 days. Subacute, whenever the duration is from 4 to 21 days. And what's the chronic SDH? In chronic SDH, the duration is more than 21 days. Sometimes they ask definition of chronic SDH in weeks. So how many weeks? More than 3 weeks. In both of these cases, obviously, investigation of choice for diagnosis is non-contrast CT, NCCT. See the finding. In the first image, you can see hyperdense lesion, which is biconvex or lenticular shaped or lens shaped. So it is biconvex, lenticular or lens shaped hyperdense lesion. This is extradural hematoma. And if you see second picture, this is concavo-convex hyperdense lesion. This is subdural hematoma. Okay, how we are going to treat it? So we have to drain it. There are two options. Either we are going to drain it by burr hole. So there is small EDH, small SDH. It can be drained by burr hole, and if it's large, it can be drained by craniotomy. So two options. Either we can drain it by making burr hole, or the second option is by craniotomy. Okay, same for SDH also. What's one good thing about SDH? That small SDH can be left, but one bad thing, overall if you compare EDH and SDH, SDH is associated with poor prognosis. Another important topic is diffuse axonal injury. So see, the term is self-explanatory. Diffuse means there is widespread axonal damage. There is widespread axonal damage involving both hemispheres. What is the most common site? The most common site is lobar white matter. It's the lobar white matter, and specifically at the junction of white matter and gray matter. So it's lobar white matter followed by corpus callosum followed by brainstem, followed by brain stem. Okay, generally these patients are brought to emergency in vegetative state. These patients have loss of consciousness. We send these patients for NCCT head and NCCT is normal. How we make the diagnosis of diffuse axonal injuries? The investigation of choice for diagnosis is MRI. And you know, diffuse axonal injury is the most common cause of post-traumatic vegetative state. So this is the most common cause of post-traumatic vegetative state, right? When these patients are brought to emergency, there is loss of consciousness. NCCT is typically normal. So you have to remember that NCCT, it's normal. What is the investigation of choice for diagnosis? It is diagnosed by MRI. Problem: diffuse axonal injury is having widespread axonal damage. That's why it's having poor prognosis, extremely poor prognosis. Now we are going to discuss neck and thoracic injuries. First, we are going to discuss the neck injuries. In neck injuries, the major vascular structures and aerodigestive structures are located in the anterior triangle deep to platysma. Anterior triangle deep to platysma. So what are the two most important landmark in neck injuries? One, platysma, and since it's located in anterior triangle, another landmark is sternocleidomastoid. So first important question, that what are the two useful anatomical landmarks in neck injury? First is platysma and the second is sternocleidomastoid muscle. There are three zones of neck injuries. So what is zone 1, zone 2, zone 3? You can see this is sternal notch and this is the cricoid cartilage. So zone between sternal notch and cricoid cartilage is zone 1. Zone 2 is between cricoid cartilage and angle of mandible. And where is the zone 3? It's located between angle of mandible to the base of skull. So this is base of skull. And zone 3, it's located between angle of mandible and the base of skull. What are the important structures located in the various zones and what are the important points which are asked in exams? Have a look. See the structures located in zone 1. There is carotid artery in zone 1 and aerodigestive structures means trachea and esophagus. These are located in zone 1. Because of injury of carotid vessels, injuries of zone 1 are having highest mortality. So zone 1 injuries, these are having highest mortality. Why? Because of injury of carotid vessels. See the zone 2. Zone 2 is most exposed. Here you can see this zone 2. It is most exposed and that's why it is most commonly injured. Zone 2 is most exposed, most commonly injured and most accessible surgically. So zone 2 is most commonly injured because this is most exposed and that's why it is most accessible zone. And the zone 3 we discussed, it is located between angle of mandible to the base of skull. See the one-liner questions related to thoracic injuries. First question, what is the most common thoracic injury? These are the chest wall injuries. So most common thoracic injuries are chest wall injuries. Okay. After that, what's the most common cause of mortality in thoracic injury? If there is blunt trauma and if there is penetrating trauma. In cases of blunt trauma, the most common cause of mortality in thoracic injury is the tracheobronchial injuries. And in cases of penetrating trauma, it is the hemothorax. Why hemothorax? Because of pulmonary laceration. So in penetrating trauma, the most common cause of mortality, it's the hemothorax secondary to pulmonary laceration. One question which was asked in AIIMS 2 to 3 times, that what is the most commonly fractured rib during CPR? So whenever you perform CPR, where is your hand? Yes, where is your hand? So we put our hand on the left side and the most commonly injured ribs are 4th to 6th rib. So we place our hand centrally. That's why most commonly injured ribs are 4th to 6th rib. If we see in rib fracture, which rib fracture is uncommon? So it's first, top and bottom. So first and 10th to 12th ribs, these fractures are uncommon. Suppose a patient is having the rib fracture of rib 1, 10th and 12th. So if these ribs are fractured, it means there is high velocity impact. So it can be seen in high velocity impact. Okay, otherwise fracture of first rib, 10th to 12th ribs are uncommon. Tension pneumothorax is very important topic. It's asked almost every year in each and every exam. What's the cause of tension pneumothorax? It is caused by one-way valve air leak either from lung, here you can see, one-way valve air leak either from lung or from the chest wall. So see the pathophysiology. What happens? During inspiration, air is forced in to the thoracic cavity, but during expiration, here you can see the valve is closed. So this is one-way valve air leak, and because of that, air is collected into thoracic cavity under tension, and that's why it's known as what? Tension pneumothorax. What are the effects of tension pneumothorax? See, because air is collected under tension, so what? It can lead to collapse of ipsilateral lung. There will be shift of mediastinum. Shift of mediastinum. Okay. Third thing, you can see it is going to cause depression of diaphragm, and it is going to compress this superior vena cava and inferior vena cava. So there is compression of diaphragm, compression of superior vena cava, inferior vena cava, and if these vena cavas are compressed, what? There is decreased venous return. And clinically, what is the sign? You can see that there is distended neck veins. So collapse of ipsilateral lung, shift of mediastinum, depressed diaphragm, compression of superior vena cava, inferior vena cava, there is decreased venous return. What are the clinical manifestations? The patients of tension pneumothorax, they have dyspnea, tachypnea. On examination, you are going to find that there is distended neck veins. Imagine that I am going to perform the percussion. On the affected side, what? There is hyperresonance because air is collected. And if you perform auscultation, what? There is absent breath sounds. So clinically, dyspnea, tachypnea, distended neck veins. On percussion, hyperresonance, and on auscultation there is absent breath sounds. Important question which you have to remember. How we are going to make the diagnosis of tension pneumothorax, and the diagnosis is made clinically. Don't send the patient for radiological investigation, otherwise you might lose patient might die in radiology department. So diagnosis is clinical diagnosis. In relation to chest injury, you have to remember that diagnosis of tension pneumothorax and diagnosis of flail chest is clinical. Imagine as X-ray is done. Imagine X-ray is performed in patient of tension pneumothorax. What are the findings? So in this X-ray also you can notice what? That there is collapsed lung, there is depressed diaphragm, there is shift of mediastinum to opposite side. So these are the findings suggestive of tension pneumothorax. How we are going to manage the tension pneumothorax? Whenever there is suspicion, clinical suspicion, immediately you have to insert a wide bore needle in second intercostal space in mid-clavicular line. But according to ATLS 2018 update, it is said that it should be inserted, wide bore needle should be inserted in fifth intercostal space slightly anterior to mid-axillary line. But in children, we are going to insert it in second intercostal space. So according to ATLS update, where to insert the wide bore needle in children, we have to insert the wide bore needle in second intercostal space. Where exactly? In the mid-clavicular line. Okay. And what about adults? According to ATLS updates, in adults, it should be inserted in fifth intercostal space slightly anterior to mid-axillary line, and generally it is anterior axillary line. It's slightly anterior to mid-axillary line, that is almost anterior axillary line. This is the emergency treatment, so that you have some time to prepare yourself for ICD insertion What's the treatment of choice? We have to insert ICD, intercostal drain or chest tube, where? In the triangle of safety, in fifth intercostal space, in anterior axillary line. So what's the treatment of choice? ICD insertion in triangle of safety, in fifth intercostal space, where exactly? In anterior axillary line. This is how we manage. Clear? So you have to remember, because nowadays they are asking the update that where you are supposed to insert the wide bore needle in adults. It's fifth intercostal space, slightly anterior to mid axillary line. In this x-ray you can see enlarged cardiac shadow. This is a case of pericardial tamponade, and this pericardial tamponade can be caused by rapid accumulation of blood or fluid in pericardial space. So this is pericardial tamponade. Okay, what's the cause? Generally it is caused by penetrating trauma. In relation to trauma, it is caused by penetrating trauma leading to rapid accumulation of blood in the thoracic space. You know, pericardial tamponade is characterized by Bake's triad. So what are the components of Bake's triad? Muffled heart sound, distended neck veins and hypotension. Muffled heart sound, distended neck veins and hypotension. So mnemonic is MDH, asli masale such. How to differentiate pericardial tamponade from tension pneumothorax? Because in both hypotension is seen, in both distended neck veins is seen, but hyperresonance on percussion is only seen in tension pneumothorax. Okay, and absent breath sounds are only seen in tension pneumothorax. In pericardial tamponade there is muffled heart sound, and in tension pneumothorax there is absent breath sound over the affected hemithorax. So this is how you can differentiate tension pneumothorax from pericardial tamponade. What is the investigation of choice for diagnosis? Investigation of choice for diagnosis is echocardiography. Okay, and if we perform x-ray, you can see there is enlarged cardiac shadow. Two kinds of treatment are there. Emergency treatment, insert the needle and perform the aspiration. It's needle pericardiocentesis. And what is the treatment of choice? We incise the pericardium and drain it, that is pericardiotomy. Emergency treatment, needle pericardiocentesis. Treatment of choice is drainage by pericardiotomy. What is the definition of flail chest? According to ATLS modification, the definition is fracture of two or more than two consecutive ribs fractured at two or more than two places. So it's the fracture of two or more than two consecutive ribs fractured at two or more than two places. So what is the problem here? Because of this, that part of chest wall is isolated. So one part of chest wall is isolated, and when one part of chest wall is isolated, during inspiration, when there is negative pressure inside, chest wall moves out, that segment goes in, and during expiration, when the positive pressure is in the thoracic cavity, your chest wall moves in, but that part of isolated chest wall moves out. Okay, this is known as paradoxical respiration. So in flail chest, the flail segment moves in opposite direction of the chest wall. This is paradoxical respiration. Because of pain, there is voluntary splinting. That's why there is mechanically impaired chest wall movement. So there is paradoxical respiration, there is mechanically impaired chest wall movement because of pain. All these leads to increased risk of respiratory failure. So in these patients, there is increased risk of respiratory failure because of paradoxical respiration and voluntary splinting leading to impaired chest wall movement. We discussed how we make the diagnosis of tension pneumothorax and flail chest clinically. So here we have to observe the patient and we have to look for what paradoxical movement of flail segment, or we have to ask the patient to cough. When the patient coughs, what happens? The thoracic cavity moves in and that flail segment moves out. How to manage the patient? Read the question carefully. If the patient is having only flail chest, we give oxygen administration. The most important aspect is what? Analgesia. That's why we give epidural analgesia if required and physiotherapy. So the treatment of flail chest. If only flail chest is there, there is no respiratory failure. In exam, if it's not mentioned respiratory failure, the treatment is oxygen administration plus analgesia. We give epidural analgesia and physiotherapy. In exam, if it's mentioned that patient is having respiratory failure also, if there is flail chest and respiratory failure, in these patients we go for intermittent positive pressure ventilation. So this is how we manage the patients of flail chest. Now we are going to discuss abdominal trauma. First, see the important one-liner questions asked in relation to abdominal trauma. What is the most commonly injured organ in blunt trauma abdomen? So you know it's spleen followed by liver. Most commonly injured organ in blunt trauma abdomen, that's spleen followed by liver. Second question, what is the most commonly injured organ in penetrating trauma? Initially it was small intestine, but at present it's liver followed by stomach followed by small intestine. So it's liver followed by stomach followed by small intestine. Right? See the twist in the question. Most commonly injured organ in gunshot injury or gunshot wound. Penetrating trauma can be because of stab wound, because of gunshot wound. But specifically if the question is asked, most commonly injured organ because of gunshot injury or gunshot wound, that is small intestine. Okay. Another question. What is the most commonly injured part of bowel in blunt trauma abdomen? The part of bowel which should be both mobile and fixed. And what's that part? It's a part of small intestine, jejunum. Jejunum is mobile, but you know, part of jejunum is fixed at DJ junction, duodenojejunal junction. So it is jejunum. Most commonly injured part of bowel in blunt trauma abdomen. Okay. Another question is related to deceleration injury. So what's the most common site of injury in deceleration injury? So again, the part of bowel which should be both mobile and fixed. So it is jejunum. And which part of jejunum? It's the duodenojejunal junction. It's the most common site of injury in deceleration injury. After that, what is the most commonly injured structure in seat belt injury? And that's mesentery. Most commonly injured structure in seat belt injury, that's mesentery. Coming to the investigations. If a patient is having blunt trauma abdomen, doesn't matter whether patient is stable or unstable, what's the first investigation done? So first investigation done in patients of blunt trauma abdomen is FAST. That is focused assessment with sonography for trauma. FAST. When FAST is positive and patient is stable, we have to confirm the findings. And how we are going to confirm the findings? With the help of CECT. So CECT is only performed in stable patients. So what's the gold standard investigation for stable patients of blunt trauma abdomen? This is CECT. These are the important one-liner questions. So let's first discuss FAST. What is the full form of FAST? It's focused assessment with sonography for trauma. What is this FAST? Nothing. It's emergency ultrasound which is done very fast. So how fast? How much time it requires? Emergency ultrasound which is done very fast. It is performed within 2 to 4 minutes. What we are going to assess with FAST? We are going to assess 4 P's. What are those 4 P's? Here you can see this is pericardial sac. This is perihepatic region, this is perisplenic region, and this is pelvis. We are going to assess pericardial sac, perihepatic region, perisplenic region, and pelvis. And in which sequence? In this sequence. 1, 2, 3, 4. So first pericardial sac, then perihepatic region, perisplenic region, and pelvis. For pericardial sac, what should be the view? It is subxiphoid transverse view. That's subxiphoid transverse view for Perihepatic region, it's right upper quadrant longitudinal view. For perisplenic region, this is left upper quadrant longitudinal view, and for pelvis, what's the view? It is suprapubic, longitudinal and transverse views. So what we are going to assess? 4 P's in this sequence. This is fast. 4 P's means 4 views are there. There is another question, what is extended fast? Also known as E-fast. In E-fast or extended fast, we are going to include right thoracic as well as left thoracic view. So when right thoracic and left thoracic view is included, how many total views? 6 views. So in E-fast, how many total views? 6 views. Right and left thoracic views are included. Question was asked in AIIMS 2 to 3 times that in patients of pneumothorax, what's the characteristic sign seen on E-fast? And that's known as barcode sign. Barcode sign, also known as stratosphere sign. Barcode sign, also known as stratosphere sign, and this sign is seen in which patients? The patients of pneumothorax on E-fast, right? So patients of pneumothorax have barcode sign, stratosphere sign on E-fast. Okay, we discussed that the first investigation done in patients of blunt trauma abdomen doesn't matter patient is stable or unstable, it is fast. And you know, fast has replaced DPL. What is DPL? Diagnostic peritoneal lavage. So what is done in diagnostic peritoneal lavage? It is the peritoneal lavage performed with 1 liter of normal saline or ringer lactate for making the diagnosis. So peritoneal lavage performed with 1 liter of normal saline or ringer lactate for making the diagnosis that what happened in the blunt trauma abdomen. How this DPL is done? Here you can see after infraumbilical midline vertical incision, we are going to insert a catheter, and this catheter is directed towards pelvis. After inserting this catheter, we are going to perform the aspiration. Okay, and after aspiration, we are going to attach it with 1 liter of normal saline or ringer lactate bottle. So here you can see this is the bottle of IV fluid. In this, either there is 1 liter of normal saline or ringer lactate. Okay, so what happens? There is lavage. After that, when the whole fluid goes into the peritoneal cavity, we put this bottle down. So whatever the fluid is collected, that effluent starts coming in the bottle, and this effluent or the lavage fluid is sent for the examination. So in which cases DPL is considered positive? So DPL is considered positive when more than 10 ml of frank blood is aspirated. When we inserted catheter, if we are going to aspirate more than 10 ml of frank blood, it is considered positive. Second, the effluent, whenever we are sending this effluent for examination, and in the effluent, if the number of RBCs is more than 1 lakh per mm cube or number of WBCs is more than 500 per mm cube, it is considered positive. Presence of bile, bacteria, fecal matter or vegetable matter is suggestive of perforation. Presence of bile, bacteria, fecal matter, vegetable matter, it is suggestive of perforation. So DPL is considered positive. And amylase level we have to check, and if the level of amylase is more than 175 international units per deciliter, in these cases DPL is considered positive. So you have to remember these 4 conditions where DPL is considered positive. Nowadays it's rarely performed. Why? Because fast has replaced the DPL. The common causes of penetrating trauma, it's the stab wound and gunshot wound. It's the stab wound and gunshot wound. Okay, so what is the most commonly injured organ in penetrating trauma? We discussed liver, followed by stomach, followed by small intestine. So it's liver, followed by stomach, followed by small intestine. Okay, second question, most commonly injured organ in gunshot wound. So we discussed it is small intestine. The one question which was asked, that in which cases exploratory laparotomy is mandatory? In all patients of stab wound, in all patients of gunshot wound. So in which case exploratory laparotomy is mandatory? What's the problem? In stab wound, sometimes in stab wound what happens, there is only CLW, clean lacerated wound. Why? Because the depth of penetration is small and the peritoneum is intact. In these cases, laparotomy is not mandatory, but in all cases of gunshot wound, exploratory laparotomy is mandatory. So exploratory laparotomy is mandatory in all patients of gunshot wound. Now let me tell you the basics of abdominal trauma. Blunt trauma abdomen. Imagine a patient of blunt trauma abdomen who is brought to your emergency. Doesn't matter patient is stable or unstable, what's the first investigation done? FAST. If patient is unstable, FAST will give you idea that what is the site of injury, where is the fluid collection, and then we take the patient to OT for exploratory laparotomy. Second situation, patient is stable. And if patient is stable, FAST is positive, in that case, we have to confirm the findings and we are going to perform CCT. If stable patient is there, FAST is positive, confirm the findings with the help of CCT, and further management is dependent on the grade of injury, and second thing, active bleeding is going or not. If you perform CCT, contrast enhanced CT, and if some active bleeding is going on, you will notice on CT that there is contrast blush, and if contrast blush is visualized on CT, means active bleeding is going on, we can control this active bleeding with the help of angioembolization. If angioembolization is not available or it's failed, in that case, we can perform the laparotomy and we can ligate the bleeding vessel or we can control the bleeding. So this is the broad management. We are going to discuss the management of splenic trauma and management of liver trauma. We discussed that the most commonly injured organ in blunt trauma abdomen is spleen. There are two signs which are asked in relation to splenic trauma. One is Keher sign and second is Balance sign. What is Keher sign? See. In patients of splenic trauma, there is collection of blood and this blood is going to irritate the under surface of diaphragm. Via C4, C5 fibers of phrenic nerve, the pain is referred to tip of left shoulder. This is Keher sign. So what happens here in Keher sign? The pain is referred to tip of left shoulder via phrenic nerve, which branches? C4, C5. Keher sign. What is Balance sign? Whenever there is coagulated blood collected in left upper quadrant around the spleen, if you do percussion, there is fixed area of percussible dullness, and this fixed area of percussible dullness around spleen is known as Balance sign. So this is fixed area of percussible dullness. Percussible dullness, okay, and this is known as Balance sign. Right? Now see how we manage the patients of splenic trauma. So in splenic trauma patients, there are two conditions, either patient is unstable or stable. If patient is unstable, obviously we perform FAST. Patient is unstable, so FAST will be positive, and in these patients we have to perform what? Exploratory laparotomy. Second situation, when the patient is stable, we go for FAST and FAST is negative. In that case, nothing is done, only observation. If FAST is positive, we discussed that we have to confirm the findings with the help of CCT. On CT, you can grade the splenic trauma. It's very easy to remember. See, high grade splenic trauma, especially grade 4 or 5, here it's very difficult to conserve or save spleen. So in grade 4 and in grade 5 splenic injuries, we go for exploratory laparotomy plus splenectomy. Exploratory laparotomy plus splenectomy. If it's low grade, like grade 1 and grade 2, generally we observe the patient. But on CT, if even in low grade patients, there is pseudoaneurysm, there is contrast blush or there is moderate bleed. So in grade 1 to grade 3, if there is pseudoaneurysm, contrast blush or there is moderate bleed, we attempt angioembolization. Suppose angioembolization is failed, or patient developed hemodynamic instability, or patient developed peritonitis. In such patients, obviously we have to go for exploratory laparotomy plus splenectomy. Second situation, imagine patient of grade 1, grade 2, grade 3. These patients are not having contrast blush, there is no pseudoaneurysm, there is no moderate bleed. We observe the patient and repeat scan is performed after 72 hours. So this is how we manage the patients of splenic trauma. In most of the patients of grade 4, grade 5, we go for splenectomy, exploratory laparotomy plus splenectomy. Grade 1 to grade 3, generally observation, but if these patients have pseudoaneurysm, contrast blush, moderate bleed, we attempt angioembolization. If it's not available or failed, we go for exploratory laparotomy plus splenectomy. Management of liver trauma is also similar. So here you can see, if the patient is unstable, we go for fast is positive, and generally we go for exploratory laparotomy. If patient is stable, in that case also we go for fast. If fast is negative, what's done? Only observation. If fast is positive, you have to confirm the findings with the help of CT. So here it's positive, we perform CT. If patient is having grade 4 or grade 5, grade 4 or more injury, in that case what's done? Exploratory laparotomy. But if it's grade 1 to grade 3, there are two things. One, observation. And if on CCT, there is contrast blush. Yes, if contrast blush is present, we go for angioembolization. Angioembolization is not available or failed. In that case, we go for what? Exploratory laparotomy. And if there is no contrast blush, in that case, we go for observation. So this is how we manage the patients of liver trauma. This is seat belt injury. So we apply seat belt. See the pattern of abrasion seen in seat belt. It is going to involve what? Neck. It is going to involve the chest, and it is going to involve what? Abdomen. Okay, so the skin abrasion is there, and it is going to involve neck, chest, abdomen. This is the pattern of skin abrasion seen in patients of seatbelt injury. The unique injury profile seen in patients with seatbelt injury, that is known as seatbelt syndrome. We discussed what is the most commonly injured structure in seatbelt injury, and it's the mesentery. This is mesentery. Is most commonly injured structure. Not only mesentery, sometimes it is associated with injury of intra-abdominal structures, especially the retroperitoneal structures, and what? There is pancreaticoduodenal injuries. Injury of intra-abdominal structures, generally pancreaticoduodenal injuries, these are associated. In seatbelt injuries, there is tear to mesentery, and there are two types of tear. One is longitudinal, and the second is transverse. If longitudinal tear is there, you can easily repair it. Why? Because the blood supply of bowel is not hampered. But if transverse tear is there, here you can see the blood supply of bowel is hampered, and in this case we have to go for resection and anastomosis. So here see the management. This is the longitudinal tear, and we can go for repair. Why? Because blood supply is not hampered. And if there is transverse tear, you can see this part of bowel is having ischemia. So what we do? We go for resection and anastomosis. This question is asked for longitudinal tear repair, and for transverse tear we go for resection and anastomosis. There is trauma triad of death. What are the components of trauma triad of death? First is hypothermia, second is coagulopathy, and third is metabolic acidosis. Okay, so it's hypothermia, coagulopathy, metabolic acidosis. It's a vicious cycle. Out of these three, which one is most commonly responsible for death, or which one is most common cause of death? Yes, that is coagulopathy. Now see what was the approach. 30 to 50 years back, in patients of blunt trauma abdomen, especially the patients who are unstable, in those cases we were going for long duration surgery. But if you go for long duration surgery, there is blood loss, there is hypothermia, so all these things are going to precipitate this vicious cycle. That's why nowadays the concept is go for damage control surgery. Damage control surgery means also known as abbreviated laparotomy. So damage control surgery means just control the damage, resuscitate the patient, and in second surgery, what? Go for definitive operation. So we are going to discuss damage control surgery. What's the other name of damage control surgery? It's also known as abbreviated laparotomy. It is also known as abbreviated laparotomy concept. You perform the surgery Yes, control the hemorrhage and contamination, shift the patient to ICU for resuscitation, so that we are going to correct hypothermia, coagulopathy, metabolic acidosis. When general condition of patient is going to improve, these things are corrected, then we go for definitive surgery. So there are 3 phases in damage control surgery. So phase 1 is initial exploration. When we take the patient to OT for laparotomy, here we go for rapid control of hemorrhage and contamination. In phase 1, we go for rapid control of hemorrhage and contamination. Clear? After that, we close the abdomen and we shift the patient to ICU for 48 hours. So phase 2 is also known as secondary resuscitation, and this is done in ICU. So shift the patient to ICU for 48 hours. What were the components of trauma triad of death? Hypothermia, coagulopathy, and metabolic acidosis. We are going to correct these things. Okay, so we correct hypothermia, coagulopathy, metabolic acidosis. Now the general condition of patient is going to improve. Again, we take the patient for surgery, where we perform the planned re-exploration. So in phase 3, we go for planned re-exploration and we go for definitive repair of injuries. So what is the other name? This is definitive operation. These are phases. In AIIMS, there was one question related to stages of damage control surgery. You can see there are 3 phases, 5 stages of damage control surgery. So what stage 1? Patient selection, that in which case we have to go for damage control surgery. Stage 2 is operative control of hemorrhage contamination. 3 is ICU resuscitation. Stage 4 is definitive surgery, and stage 5 abdominal closure. What you're going to notice here, that stage 2, 3, 4, it's a component of phases. So stage 2 is phase 1, stage 3 is phase 2, and stage 4 is phase 3 of damage control surgery. So in the exam, you have to read the question carefully, whether stages is being asked or phases is being asked. What's the normal intra-abdominal pressure? It is 5 to 7 mmHg. Okay. And what's the definition of intra-abdominal hypertension? Whenever the intra-abdominal pressure is more than 12 mmHg. Now, abdominal compartment syndrome. Whenever the intra-abdominal pressure is more than 20 mmHg. What is the effect? Whenever the pressure is more than 20 mmHg, the diaphragm is pushed up and there is compression of IVC and vessels in the abdomen. So if there is compression of inferior vena cava vessels in the abdomen, it leads to mesenteric vascular compromise. Diaphragm is pushed up, so it can lead to pulmonary failure. So because of abdominal compartment syndrome, there can be fatal complications. Yes, and because these complications are because of mesenteric vascular compromise and because of pulmonary failure. Now see the pathophysiological consequences of abdominal compartment syndrome. What are the parameters which are decreased and what are the parameters which are increased? So it's very easy to understand. Whenever there is increased intra-abdominal pressure, there is compression of inferior vena cava. So what will happen? There is decreased venous return to the heart. If there is decreased venous return to the heart, what will happen? There is decreased cardiac output. And if there is decreased cardiac output, what? It can lead to decreased renal blood flow and it can lead to decreased visceral blood flow. What? Decreased renal blood flow and decreased visceral blood flow. Because of decreased renal blood flow, there is decreased GFR and decreased urine output. So there is decreased GFR and there is decreased urine output. So what you have noticed here, 2 things. 1, there is decreased cardiac output. It means in the patients of abdominal compartment syndrome, there is hypotension. Second, in these patients, there is decreased urine output. It means what? Initially, these patients are going to develop oliguria and then anuria. Clear? So here you can see decreased cardiac output. So patients are going to have hypotension. decreased urine output. So these patients are going to develop oliguria and anuria, right? So these are the parameters which are decreased. What are the parameters which are increased? Diaphragm is pushed up. When diaphragm is pushed up, what's the problem? There is increased peak inspiratory pressure. There is increased pulmonary capillary wedge pressure, increased intrapleural pressure. CVP is also increased. Heart rate is increased, so increased cardiac rate, and there is compression of vessels. That's why there is increased systemic vascular resistance. So how to remember the mnemonic is increased peaks in abdominal compartment syndrome. Increased peaks in abdominal compartment syndrome. So there is increased peak inspiratory pressure, pulmonary capillary wedge pressure, intrapleural pressure, CVP, cardiac rate or heart rate, and systemic vascular resistance. Because of increased peak inspiratory pressure, the patient is going to develop hypoxia and hypercapnia. So these are the manifestations: hypoxia, hypercapnia. So easy to remember. What are the manifestations? These patients are going to develop hypotension, oliguria, further leading to anuria. Patients are having hypoxia and hypercapnia. How to measure intra-abdominal pressure? You can measure it indirectly by measuring the bladder pressure. So insert bladder catheter, measure the bladder pressure. Indirectly, you can measure the intra-abdominal pressure. So what's the gold standard indirect method for measuring intra-abdominal pressure? This is with the help of urinary bladder catheter. So gold standard method for measuring intra-abdominal pressure, it's with the help of urinary bladder catheter, because indirectly bladder pressure represents what? Intra-abdominal pressure. There is grading of abdominal compartment syndrome, and the management of abdominal compartment syndrome is dependent on the grading. There are 4 grades. In grade 1, the bladder pressure is 12 to 15 mmHg, and generally no clinical features are seen in such patients, right? And how to go for treatment? In these cases, we go for normovolemic resuscitation. What we do? We go for normovolemic resuscitation. Whenever the grade is 2 and the pressure is 16 to 20 mmHg, such patients are going to develop oliguria and splanchnic hypoperfusion. So what are the manifestations? These patients are going to develop oliguria and splanchnic hypoperfusion. Okay. In grade 1, we go for normovolemic resuscitation, but here we go for hypovolemic resuscitation. So in grade 2, we go for hypovolemic resuscitation, right? In grade 3, how much is the pressure? 21 to 25 mmHg. Here, the patient is going to develop anuria, and there is increased ventilation pressure. Increased ventilation pressure. Okay, it's an emergency. So what we have to go for? We have to perform decompression. In grade 3, we perform decompression, right? And in grade 4, the pressure is more than 25 mmHg. Here, apart from anuria and increased ventilation pressure, there is decreased PO2. Decreased PO2, and in such patients, what's done? Emergency re-exploration. So we perform emergency re-exploration in grade 4, right? This is the question which is frequently asked: grading and the pressure of abdominal compartment syndrome. So this is how we manage the patients of abdominal compartment syndrome. See the one-liner questions related to renal trauma. So first question, what's the most commonly injured part of urinary tract? Obviously, it's kidney. Most commonly injured part of urinary system or urinary tract, kidney. And what is the most common cause of renal trauma? It's the road traffic accident. Okay. In which patients we are going to suspect that there is traumatic urinary system injury, or there is trauma to urinary system. Yes, if the patient is having hematuria. So best predictor of traumatic urinary system injury, it's the hematuria. Now coming to the investigations. If patient is stable, we can go for CCT. So investigation of choice for stable patients of renal trauma, CCT. The investigation of choice for diagnosis of renal injury in stable patients, it is CCT. Imagine that the patient is unstable. We don't know the status of kidney which is injured. That's why sometimes we have to go for nephrectomy. So you should know that what's the condition of contralateral kidney. So to assess the contralateral kidney, whether it's functioning or not, we go for single shot IVP in patients who are unstable. So what is the investigation of choice for diagnosis of renal injury in unstable patients? We go for single shot IVP. Why? To assess the contralateral kidney, whether it's functioning or not. So these are important points related to renal trauma, and this is all about trauma. Now we are going to discuss transplantation. First, we are going to discuss one-liner questions related to history of organ transplantation. Who performed first renal transplantation? It was done by Murray in identical twins. And who performed first liver transplantation? It was done by Stargell. So first question, first renal transplantation was done by Murray in identical twins, and first liver transplantation, it was done by Stargell. Who performed first pancreas transplantation? It was performed by Kelly and Lilhay. First pancreas transplantation, it was performed by Kelly and Lilhay. First heart transplantation was performed by Christian Barnard. It was performed by Christian Barnard. First lung transplantation was performed by Fritz de Rome. Who performed it? Fritz de Rome. Okay. There are two questions related to pancreatic transplantation. One, who performed first pancreas transplantation? And the second question is, who performed first pancreatic islet cell transplantation? Islet cell transplantation, and it was performed by Sutherland. It was first time performed by Sutherland. Who performed first heart and lung transplantation? It was performed by two surgeons, Reeds and Shumway. First heart plus lung transplantation performed by Reeds and Shumway. Okay, and what about intestinal transplantation? First successful intestinal transplantation, it was performed by Deltz and colleagues. First successful intestinal transplantation was performed by Deltz and colleagues. So these are important one-liners you have to remember. Now see what are the types of grafts in relation to transplantation. First, it's the autograft. So whenever tissue from one site is transplanted to other site in the same individual. So within an individual, tissue from one site is transplanted or used for another site, that is autograft. Whenever the graft is being taken from identical twins, this is known as isograft. Graft is taken from identical twins. Third type is whenever some family member is going to donate the organ. It means the organ or graft is being taken from the same species, and this is known as allograft. This is also known as homograft. Allograft, also known as homograft, where the graft is taken from the individual of same species. And whenever we are taking the graft from different species, this is known as xenograft, also known as heterograft. Xenograft or heterograft. So these are again frequently asked in exam. Types of grafts. You know, our immunity fights mainly against infection and cancer cells. So the patients in whom we are going to perform the transplantation, obviously we give immunosuppressive agents. So what are the main complications of immunosuppression? So obviously the main complications are first infection and the second is malignancy. So there is high risk of opportunistic infection in transplant recipients. There is increased risk of infection by both bacteria and viruses, but the high risk of opportunistic infection, it's mainly because of viruses. Okay. After transplantation, the bacterial infection incidence is maximum in the first month. So bacterial infection maximum incidence is seen in the first month after transplantation. And if you see the viral infection, there is maximum incidence in the first 6 months. In the first 6 months. Okay. One question which is frequently asked in relation to infection in transplant recipient, that which virus is the most common problem for the infection, and it's the cytomegalovirus. This is the most common problem in transplant recipient. Okay. Now see, what's the cause? So sometimes this virus is already there in the body and there is reactivation of latent virus, and sometimes there is primary infection. So what's the cause? Sometimes it's reactivation of latent virus, reactivation, and sometimes there is primary infection of cytomegalovirus. So important one-liners: first, in the first month of transplantation, maximum risk is for bacterial infection. First 6 months for viral infection, the most common problem is cytomegalovirus. Coming to the first question, that what's the most common malignancy seen in transplant recipients, and it's the skin malignancy or it's the skin cancer. Skin malignancy or the skin cancer. Second question, what's the most common type? And this is squamous cell carcinoma. You have to remember, this is the question asked frequently. Most common malignancy seen in transplant recipients, skin malignancy. Most common type, squamous cell carcinoma. Apart from squamous cell carcinoma of the skin, there is increased risk of PTLD. That's post-transplant lymphoproliferative disorder. And the second is what? Kaposi sarcoma. In the NEET PG, for the first time, this classification was asked, known as Maastricht classification, and this is for DCD donors. What is full form of DCD donors? Donation after circulatory death donors. DCD donors, donation after circulatory death donors. These are also known as non-heart beating donors. Name of classification is Maastricht classification. According to this classification, there are 5 categories. What is category 1? Patient is dead on arrival at hospital. Okay, and we are harvesting the organ from this patient. Second is resuscitation attempted without success. If you see the third one, awaiting cardiac arrest after withdrawal of support. So in hospital setup, patient is admitted and we are awaiting cardiac arrest after withdrawal of support. If you see, it's the category 3 which is the most commonly used. So among DCD donors is the category 3 which is most commonly used. Okay, so the most DCD donors belong to category 3. This was the indirect question in NEET PG. Category 3, most of the DCD donors belong to category 3. What's category 4? There is cardiac arrest while brain dead. Patient is already brain dead and cardiac arrest occurred. Category 5, cardiac arrest, but there is unsuccessful resuscitation at hospital. So these are 5 categories. So how to remember this classification? It's very easy to remember. The mnemonic is Dracula. D, dead on arrival at hospital. R, resuscitation attempted without success. A, awaiting cardiac arrest after withdrawal of support. C, cardiac arrest while brain dead. And this U and L means unsuccessful. So cardiac arrest and unsuccessful resuscitation at hospital. And we discussed most DCD donors belong to category 3. This is the question. There is a second problem. See, some patient who is having hepatic failure or the patient who is having chronic renal failure, that patient is requiring the organ, but healthy donors are not available. Imagine a donor is there whose kidney is already diseased or whose liver is already diseased. So if a donor is having diseased organ and we are using these organs for transplantation, this is known as extended criteria donors. So what are the extended criteria donors for kidney transplantation? First, if the age of patient is more than 60 years. Second, if the age of patient is between 50 to 59 years with at least two of the following. What? Either patient is having cerebrovascular accident, patient is having pre-existing hypertension, or the terminal serum creatinine is more than 1.5 milligram per deciliter. So out of these three, if two are present, yes, that is included in extended criteria donors. Age more than 60 or age 50 to 59 years with at least two of the following. And for liver transplantation, if the patient is having mild to moderate steatosis, or patient is hepatitis C virus positive, or patient is having hepatitis B core antibody positivity status. So three things: mild to moderate steatosis, hepatitis C positive, or patient is hepatitis B core antibody positive. Okay, so these are the extended criteria donors for kidney transplantation and for the liver transplantation. Whenever we harvest organs from the donor's body, there is optimal storage time for the graft and there is safe maximum storage time. The optimal storage time is maximum for kidney and the safe maximum storage time is also maximum for kidney. So how much? It's less than 18 hours and safe maximum storage time, and that is 36 hours. It is 36 hours. For liver, it's less than 12 hours optimal storage time and 18 hours. What? The safe maximum storage time. If you see the pancreas, optimal storage time is less than 10 hours and the safe maximum storage time is like liver. How much? 18 hours. It's 18 hours. For small intestine, it is less than 4 hours. You have to remember. Optimal storage time is less than 4 hours for small intestine and the safe maximum storage time, that is 6 hours. Okay. In cases of lungs and heart, in cases of lungs and heart, the optimal storage time, it's less than 3 hours. You have to remember. But if you see the lungs, the safe maximum storage time is 8 hours. But for the heart, it is 6 hours. For the heart, it is 6 hours. Clear? So what you have to remember, and the questions which are asked, maximum optimal storage time, it's for kidney. How much? Less than 18 hours. And safe maximum storage time is also for kidney, 36 hours. Minimum optimal storage time is for heart, that is less than 3 hours, and maximum storage time is also for the heart, and that is 6 hours. So these values you have to remember. Sometimes there is a direct question asking the optimal storage time of the organ or safe maximum storage time. Now we are going to discuss important questions related to liver transplantation. One question which is frequently asked, that's what are the indications of liver transplantation? So what's the most common indication? It is HCV induced cirrhosis. That's hepatitis C virus induced cirrhosis followed by alcoholic liver disease. Most common is not alcoholic liver disease. It is hepatitis C virus induced cirrhosis followed by alcoholic liver disease. And what's the most common indication of pediatric liver transplantation? We discussed many times. It's biliary atresia. This is biliary atresia. What is the most common metabolic disorder requiring liver transplantation? And that's alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. And what's the most common indication for liver transplantation following acute liver failure? And that is acetaminophen acetaminophen toxicity. Okay, so it's acetaminophen toxicity. These are one-liner questions related to indications of liver transplantation. Most of the questions in liver transplantations are related to orthotopic liver transplantation. What is orthotopic? What is heterotopic? When the graft is placed in the organ bed, it is orthotopic, and whenever the graft is going to be placed at some other site, not in the organ bed, that's heterotopic. So what's the sequence of anastomosis in orthotopic liver transplantation? Let me tell you, venous anastomosis are done first. So first you have to restore the venous drainage, then only you go for arterial supply. So here, what is the sequence of anastomosis? The first is suprahepatic IVC. This is suprahepatic IVC, first anastomosis. This second is infrahepatic IVC. Okay, the third is this one, and this is portal vein. The third anastomosis is of portal vein. Fourth, that is of hepatic artery, and the fifth is what? Bile duct. So what's the sequence of anastomosis? Suprahepatic IVC, infrahepatic IVC, portal vein, hepatic artery, bile duct. How to remember? The mnemonic is SIF-B. It's the SIF-B. Another question. Whenever we are going for bile duct anastomosis, there are two kinds of anastomosis which can be done. Imagine that this is the liver graft, and this is the bile duct of graft, and this is the bile duct of recipient. So when anastomosis is between the bile duct of graft and recipient, this is known as choledochococholedochostomy. In short, CDCD. Choledochocoledochostomy. Second situation, that this is the graft, okay, and this is the bile duct of graft, and this is being anastomosed with what? Jejunum. It's the jejunum. So this is Roux-en-Y choledochojejunostomy. What's the name of anastomosis? Choledochojejunostomy, and the first is choledochocoledochostomy. So which one is preferred in liver transplantation? Is choledochocoledochostomy preferred over choledochojejunostomy? In which cases we go for choledochojejunostomy? See, if there is diseased extrahepatic bile duct, in the recipient there is diseased extrahepatic bile duct like primary sclerosing cholangitis, so you have to excise diseased extrahepatic bile duct, and obviously you have to perform the anastomosis with bile duct and what? The jejunum. The second is, if there is significant donor and recipient bile duct mismatch, so it's very difficult to perform the anastomosis if there is mismatch in the size. So two indications: if there is diseased extrahepatic bile duct and there is significant donor recipient bile duct mismatch, in these cases we go for choledochojejunostomy. What's the most common cause of death after liver transplantation? It is sepsis. Not only after liver transplantation, even after heart transplantation, after small bowel transplantation, in all these cases, the most common cause of death, it's sepsis. In liver transplantation, heart transplantation and small bowel transplantation, most common cause of death after transplantation is sepsis. There are two scores which are frequently asked in exam. One is MELD score and second is PELD score. What is the full form of MELD score? Model for end stage liver disease, and PELD score, pediatric end stage liver disease. See the components. For MELD score, the mnemonic is CBI. Components are creatinine, bilirubin and INR, international normalized ratio. And for the PELD score, mnemonic is NABIA. It's NABIA. Full form: N, nutrition; A, age; B, bilirubin; I, INR; A, albumin. This is very important. You have to remember the components of MELD score and PELD score. Now see the important points related to renal transplantation. First question, that for renal transplantation, which kidney is preferred? We prefer left kidney. And why we prefer left kidney? Here you can see, because of longer left renal vein. So the left renal vein is longer. It helps in vascular anastomosis. So left kidney, it's the left kidney which is preferred. Okay. we are taking this left kidney and this renal graft is placed where? In the iliac fossa. So here you can see it is placed in iliac fossa. So the graft is placed in iliac fossa. Tell me, this kind of transplantation is orthotopic or heterotopic? So graft is placed at an alternative site, not in the organ bed. This is heterotopic. So most of the renal transplantations are heterotopic. Second important thing, here you can see that the diseased kidneys are generally not removed. Okay, so after transplantation, how many kidneys are there in the recipient? You can see total 3 kidneys, 2 diseased kidney and 1 healthy kidney. So total 3 kidneys are there. Now see the important questions related to the vascular anastomosis. There are 2 kinds of donors. One, living donor, and the second is cadaveric donor. What is the advantage of cadaveric donors? In these cases, we can take a patch of aorta along with origin of renal artery. So renal artery along with patch is being taken from the cadaveric donor, and the patch is known as Carrel's patch. So this is a cadaveric donor kidney, cadaveric donor kidney in which renal artery is removed with a Carrel's patch around it. So here you can see the vascular anastomosis is being performed between, yes, renal artery and external iliac artery. So in this case, the vascular anastomosis is being performed with renal artery and external iliac artery. If you see the living donors, in that case, here you can see the vascular anastomosis being performed between renal artery and what? It's the internal iliac artery. Can you see here? Proximal internal iliac artery. So this is the difference. And if you see the venous anastomosis, that's same. It is between renal vein and external iliac vein. So in both of these cases, you can see it is same. Okay. So how to remember? Easy. In cadaveric donors, the arterial anastomosis is between renal artery and external iliac artery, whereas in healthy donors, it is between renal artery and internal iliac artery. The venous anastomosis is same in both. It's between renal vein and external iliac vein. The question which is frequently asked related to heart transplantation and lung transplantation is the sequence of anastomosis in heart transplantation and lung transplantation. So first see what's the sequence of anastomosis in heart transplantation. So here you can see the first anastomosis is left atrial anastomosis. So this is what? Left atrial anastomosis. Second anastomosis is what? Right atrial anastomosis. And the third anastomosis is pulmonary artery anastomosis. And the fourth is what? Aortic anastomosis. So what's the first one? Is the left atrial anastomosis. Second is right atrial anastomosis. Third is pulmonary artery anastomosis. And the fourth is aortic anastomosis. Okay, so how to remember? The mnemonic is Lara Para. It's Lara Para. LA means left atrial anastomosis. First, RA means right atrial anastomosis. Second, P means pulmonary artery anastomosis, and AR means aorta. So fourth is aortic anastomosis. This is the sequence of anastomosis in heart transplantation. Now see the sequence of anastomosis in lung transplantation. This is pulmonary vein. Okay, this is the left atrium. So the first anastomosis is left atrial anastomosis or left atrial attachment, also known as pulmonary vein attachment. So what's the first one? It's the pulmonary vein attachment. This is the first. What is the second one? Here you can see there is bronchial attachment. So second is bronchial attachment. And what's the third anastomosis? Pulmonary artery attachment. So here you can see this attachment. Yes, pulmonary artery. So third is pulmonary artery attachment. So how to remember? PV means per vaginal examination by BAPA. Mnemonic is PV by BAPA. Bachelor of Arts, PA. Okay, so PV means first anastomosis is pulmonary vein attachment, second is bronchial attachment, and third is pulmonary artery attachment. So this is the sequence of anastomosis in lung transplantation. So these are important questions related to transplantation. Now we are going to discuss important topics of robotics, laparoscopy and bariatric surgery. First question, which needle is used for creation of pneumoperitoneum? It's the Wierus needle. This Wierus needle is used for creation of pneumoperitoneum. Okay, there are two methods of creation of pneumoperitoneum. One is closed method and one is open method. For closed method, the Wierus needle is used, and in the open method we are going to use Hassan cannula. So the name of this cannula, it is Hassan cannula, and this Hassan cannula is used to create pneumoperitoneum, and this method is open method. Okay, we create pneumoperitoneum, we are going to insert the trocar. Question is asked that what are the layers which are penetrated by trocar. In this image you can see this is the trocar, and this trocar is going to penetrate these layers of abdominal wall. So what are the layers penetrated? First we are going to penetrate the skin. After skin there is superficial fascia. After superficial fascia there is deep fascia. So second is superficial fascia, third deep fascia. After that there is fascia transversalis, and then there is parietal peritoneum, and then we enter into the peritoneal cavity. So these are the 5 layers which are penetrated by trocar. The important one-liner questions which are asked in relation to laparoscopy. First question is, what is the most commonly used gas in creation of pneumoperitoneum? And you have seen in the OT, it is carbon dioxide. So most commonly used gas for creation of pneumoperitoneum, it's carbon dioxide. What is the flow of carbon dioxide in creation of pneumoperitoneum? You have to remember, it is 1 liter per minute. The flow of gas, it's 1 liter per minute. Whenever we are going to create pneumoperitoneum in laparoscopy, intra-abdominal pressure should be maintained between 12 to 15 mmHg. It's 12 to 15 mmHg. See these images. Here you can see a natural orifice is used to enter into peritoneal cavity. What? A natural orifice is used to enter into peritoneal cavity, and this is known as natural orificial transluminal endoscopic surgery. In this image you can see I'm going to insert a long endoscope via mouth. After that I'm going to perform gastrotomy and then enter into the peritoneal cavity, perform the cholecystectomy, and I'm going to take out the gallbladder. See the second picture. There are 2 approaches. One is transvaginal. So here you can see from vagina I'm going into uterus and I'm performing a nick or tear into the uterus, and after that I enter into peritoneal cavity, perform cholecystectomy, or sometimes I perform appendectomy and take the specimen out. The surgery can be done via transrectal approach also. From rectum you are going to insert the endoscope, you are going to perform a small tear or nick into the rectum, enter into peritoneal cavity, perform cholecystectomy or appendectomy and take out the specimen. So what's the name of this surgery? Natural orificial transluminal endoscopic surgery. Notes. Okay, and generally what are the natural orifices used? We use mouth, rectum, vagina. 2 successful surgeries has been done, and one is what? Cholecystectomy, and the second is appendectomy. Cholecystectomy and appendectomy. Okay, by this notes. There is one modification of notes known as POEM. And what's the full form of POEM? This is per oral endoscopic myotomy. We discussed myotomy is performed for generally motility disorders of esophagus. Which one? Achalasia cardia. So this per oral endoscopic myotomy, it is performed for achalasia cardia, and it's a type of notes. So POEM, it is performed for achalasia cardia. It's a type of notes. Name of this robot is Da Vinci robot. In this, the surgeon is the master and the robot acts as a slave. We need one assistant who is going to change the instrument in the arms of robot. So this Da Vinci robot is the most commonly used robot worldwide, and it is based on which principle? Master-slave principle. Surgeon is the master and robot is the slave. So Da Vinci robot works on master-slave principle. In which types of surgery we are using robot nowadays? It is used in the surgeries where the operative field is smaller. Imagine I'm going for cardiac valve repair. The operative field is smaller. So it is used for cardiac valve repair, for prostatectomy, and for gynecological operations. So this was the question in a latest exam, that what are the indications of robotic surgery? It is used in prostatectomy, it is used in cardiac valve repair, and it is used in gynecological operations. Now we are going to discuss bariatric surgery. Bariatric surgery includes the surgical procedures performed for the treatment of obesity. Okay, nowadays it is commonly performed. See what are the indications of bariatric surgery. So first, if the BMI is more than equal to 35 kg per meter square plus comorbidity, and the second is if BMI is more than equal to 40 kg per meter square with or without comorbidity. It doesn't matter patient is having comorbidity or not. So first, BMI more than 35 kg, more than equal to 35 kg per meter square with comorbidity, and BMI more than equal to 40 kg per meter square with or without comorbidity. This is for international patients. So this is for international patient. So according to international standards, this is the indication. But if we are talking about Asian population, yes, for Asian population, this more than equal to 35 becomes 32.5, and this more than equal to 40 becomes 37.5. So what you have to do, you have to subtract 2.5 in both indications. So what are the indications of bariatric surgery in Asian population? In Asian population, it's BMI more than equal to 32.5 kg per meter square plus comorbidity, or the second is BMI more than equal to 37.5 kg per meter square with or without comorbidity. What are the types of bariatric operations or types of bariatric surgery? First is VBG, that's also known as vertical banded gastroplasty. Second is LAGB, and that's also known as laparoscopic adjustable gastric banding. Third is RYGB, and the full form is Roux-en-Y gastric bypass. Third is this RYGB. Fourth is BPD, also known as biliopancreatic diversion, and the fifth is duodenal switch. On the basis of mechanism of predominant action, these types are divided into restrictive and malabsorptive types. So see, this vertical banded gastroplasty and laparoscopically adjustable gastric banding, these are purely restrictive. What kind of surgery? These are purely restrictive. If we see Roux-en-Y gastric bypass, this is largely restrictive, mildly malabsorptive. So this is largely restrictive, okay, and mildly malabsorptive. If we see biliopancreatic diversion and duodenal switch, these are largely malabsorptive, mildly restrictive. So these are largely malabsorptive and mildly restrictive. These are mildly restrictive. Okay. First question. Second, in AIIMS the question was asked, out of these 5 worldwide, which one is most commonly performed? And it's the Roux-en-Y gastric bypass. Worldwide, this is the most commonly performed procedure. Most commonly performed procedure worldwide, Roux-en-Y gastric bypass. Out of these 5, if you see which one is safest and reversible, it is LAGB, laparoscopically adjustable gastric banding. So LAGB, this is safest and reversible. Safest and reversible. Okay, these are one-liner questions which are asked. Now let's discuss bariatric surgery in detail. What's the name of this procedure? Vertical banded gastroplasty. So here you can see vertically we are going to fire the staples. So vertically staples are fired. Banded, so we are going to apply a band over the lesser curvature of stomach so that a small pouch is created. Can you see here? A small pouch is created. So this is known as vertical banded gastroplasty, in which staples are applied vertically and a band is applied over the lesser curvature so that you are going to create stomach which is having small capacity, right? This is purely restrictive. The second is laparoscopically adjustable gastric banding. So it is laparoscopically adjustable gastric banding. So we have to apply adjustable band laparoscopically around, you can see, around the proximal part of stomach. Clear? And this is silicone band. So this is silicone band which is applied around the proximal part of stomach laparoscopically. We discussed this is safest and reversible procedure, and again this is purely restrictive. This is Roux-en-Y gastric bypass. So you can see this limb is Roux limb and this limb is Y limb. Roux limb, Y limb. What should be the length of this Roux limb? The length of Roux limb should be 70 to 100 centimeter. First question. This is Roux-en-Y gastric bypass. So we are going to bypass the major part of stomach. So here you can see we create a small gastric pouch, content 30 to 50 ml, right? And from this small pouch of stomach you are going to perform the anastomosis with Roux limb of jejunum. So this is Roux-en-Y gastric bypass. So this part of stomach means the rest part of stomach is bypassed. Worldwide, this is most commonly performed procedure, and we discussed it is largely restrictive, mildly malabsorptive. See these two images. First is biliopancreatic diversion. Two important points related to biliopancreatic diversion, that this is the most effective bariatric surgery. And since it's most effective bariatric surgery, it is associated with maximum weight loss. In biliopancreatic diversion, if it's done, it's associated with maximum weight loss. Okay. What is done in biliopancreatic diversion? Term is self-explanatory. Bile and pancreatic juice is diverted. Bile and pancreatic juice is required for digestion. So here you can see this is the liver, this is the gallbladder, this is the bile duct, okay, pancreas. So what happens generally, we perform cholecystectomy, we perform appendectomy, and we perform distal gastrectomy. Here you can see the part of stomach is removed. So which parts are removed? Cholecystectomy, gallbladder is removed, appendix is removed, distal part of stomach. Cholecystectomy, appendectomy, and distal gastrectomy. Now see the anastomosis done. Okay, we are going to divide the ileum. Okay, what's the anastomosis done in biliopancreatic diversion? We have to divide the small intestine generally at the level of jejunum and ileum. After dividing it, what? The ileum is anastomosed with the stomach. Ileum is anastomosed with the stomach. So what's the name of this anastomosis? Gastroileostomy, right? And the jejunum is anastomosed distal part of ileum. So what's the name of anastomosis? Jejunoileostomy, right? Via this jejunoileostomy, what? The bile and pancreatic juice enters where? Into the ileum. And from this gastroileostomy, what? Food is going to enter. The problem that the common channel for bile, pancreatic juice and food is only 50 centimeter. So what? Food before being absorbed enters into colon and excreted into the stool. Clear? So these are the important points. But what's the problem? Since this anastomosis is gastroileostomy, from stomach acid enters into ileum. So at the site of gastroileostomy, there is formation of stomal ulcers. So what's the problem? Main problem that there is formation of stomal ulcers at gastroileostomy. Simple. That's why we are going to modify this surgery. And what we are going to do, in between the stomach and ileum, we have to introduce part of duodenum, and that's known as duodenal switch. So rather than going for distal gastrectomy, we go for sleeve gastrectomy in duodenal switch, where 70 to 80% of stomach is removed. First part of duodenum is retained and the ileum is anastomosed with first part of duodenum. So anastomosis is duodenoileostomy. Here this is jejunoileostomy. Clear? And in this case, the common channel is 100 centimeter. So in comparison to biliopancreatic diversion, here the weight loss severity is lesser and the side effects are also lesser. Apart from that, you can see we perform cholecystectomy, we perform appendectomy. So what are the organs removed? Gallbladder, appendix. What kind of gastrectomy is done? Sleeve gastrectomy. And what kind of anastomosis? Duodenoileostomy, between first part of duodenum and ileum, and jejunoileostomy. So this is duodenal switch. Both of these are largely malabsorptive, mildly restrictive. Now see the important one-liner questions related to mortality, perioperative mortality in bariatric surgery. The people who are going for bariatric surgery, obviously they are obese, generally morbidly obese, and obesity is one of the risk factor. Bariatric surgery duration is longer and patient is immobilized for long duration. So what happens? There is increased risk of DVT and pulmonary embolism. So the most common cause of death within 30 days of surgery, obviously it's pulmonary embolism, followed by cardiac complications, followed by cardiac complications, followed by anastomotic leak because so many anastomosis are being done, followed by anastomotic leak. Okay, now see the twist in the question. Most common cause of death in immediate postoperative period. In immediate postoperative period, death occurs because of peritonitis. And why there is peritonitis? It's because of anastomotic leak. So in immediate postoperative period, the most common cause of death is anastomotic leak leading to peritonitis. In bariatric surgery, which anastomosis is having maximum risk of leak? And it's the gastrojejunostomy. Which anastomosis? Gastrojejunostomy is having the maximum risk of leak. So these were the important questions related to robotics, laparoscopy and bariatric surgery. Now we are going to discuss sutures and anastomosis. Sutures are broadly divided into two types: absorbable sutures and non-absorbable sutures. Absorbable means absorbed in the tissues because of phagocytosis or enzymatic digestion. Non-absorbable, it means it is going to persist for indefinite period of time in tissues. These sutures are further divided into natural absorbable and synthetic absorbable, natural non-absorbable and synthetic non-absorbable. So first see what are the natural absorbable and non-absorbable suture. It's catgut and chromic catgut. Catgut and chromic catgut, these are the natural absorbable sutures. And what are the natural non-absorbable sutures? Silk and the linen. Silk and linen. Now the synthetic sutures. First, synthetic absorbable sutures. So it's easy to remember the synthetic absorbable sutures, and the mnemonic is PVD. P means polyglycaprone, polydioxanone. V means Vicryl, D means Dexan. Okay. What are the other names of these sutures? Polyglycaprone, the other name is monocryl, and in names this question was asked. that which suture is used for subcuticular suturing, it's the monocryl. Monocryl. That's polyglycaprone. What's the other name of polydioxanone? In short, we call it as PDS. You know, Vicryl, other name of Vicryl is polyglactin. Vicryl, other name is polyglactin. And you know what's the other name of Dexan? It's polyglycolic acid. This is polyglycolic acid. Okay, these are the synthetic absorbable sutures. Now see synthetic non-absorbable sutures. How to remember synthetic non-absorbable sutures? And the mnemonic is PEN. P means proline, polyester, E means ethylon, N means nylon. So these are the two category of sutures, absorbable and non-absorbable. It is further divided into monofilament and polyfilament. Monofilament, if there is a single strand, smooth and strong, it's monofilament. And when multiple strands are braided together, so when multiple strands are braided together, this is known as polyfilament suture. What's the problem with polyfilament suture? You can see in between the strands there is space, that's known as crevices. So bacteria can be lodged in these crevices, leading to increased risk of infection. But what's the advantage of this polyfilament suture? That here knots are more stable. So generally we take 3 to 4 knots in polyfilament suture, but how many knots are required in monofilament sutures? Yes, 6 to 8. So the further division, it's monofilament and polyfilament. Monofilament and polyfilament. Clear? Advantage of monofilament suture, that there is decreased risk of infection, but disadvantage that the knots are less stable, so we have to take 6 to 8 knots. Advantage of polyfilament, that knots are stable, so generally 3 to 4 knots are required, but the disadvantage, there is presence of crevices between the strands, so there is increased risk of infection. What are the examples? So monofilament can be remembered by the same mnemonic PEN: proline, ethylon, nylon. See the polyfilament sutures. For polyfilament, the mnemonic is SLIP. S means silk, Li, that's linen, and P is polyglycolic acid. And we discussed what's the other name of polyglycolic acid. This is Dexan. So these are monofilament and polyfilament sutures. One by one, we are going to discuss the sutures in detail, which are frequently asked in exams. So here you can see this suture is catgut. Okay. Catgut, it's not the catgut, it is prepared from sheep gut. And from which layer? It is prepared from submucosa of sheep's ileum. Submucosa of sheep's ileum. It's natural absorbable suture, so we use a preservative solution, and that is isopropyl alcohol. We use isopropyl alcohol as a preservative solution for catgut, and catgut is absorbed in how many days? 60 days. It's absorbed in 60 days. So see the appearance? This is catgut. Whenever catgut is tanned with chromium salt, then it's known as chromic catgut. And the question is asked related to chromic catgut, that in how many days this chromic catgut is absorbed, and this is absorbed in 60 to 90 days. So chromic catgut, this is absorbed in 60 to 90 days, catgut in 60 days. What's the name of this suture? This is Vicryl. And the other name of Vicryl is polyglactin. It's polyglactin. First question, that this Vicryl or polyglactin, it's a copolymer of glycolide plus lactide. First question, is the copolymer of glycolide plus lactide. Okay, it's the workhorse sutures of general surgeons. You have seen in the OT, general surgeons are shouting for Vicryl, 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 Vicryl. So it's the workhorse suture for general surgeons. This is delayed absorbable sutures. So any organ in which there is increased risk of stone formation, like CVD, like bladder, like ureter. So in all these organs, we are using what? Vicryl. So Vicryl is used in the organs where there is increased risk of stone formation, and the mnemonic is CUB. C is CBD, U means ureter, and B means bladder. Okay, this Vicryl is absorbed in 60 to 90 days. It is delayed absorbable sutures. It is type of delayed absorbable suture, absorbed in 60 to 90 days. We can identify it with the color. Can you see the color? Color is violet, and if you see this suture, you can see the multiple strands are braided together. So it is monofilament or polyfilament. It's a type of polyfilament suture. This is monocryl. Okay, what is the other name of monocryl? It's polyglycaprone. It's the polyglycaprone. How to remember? Poly, so it is copolymer of what? Glycolide. Copolymer of glycolide, caprone, that is caprolactone. Caprolactone. Clear? So monocryl, it's polyglycaprone, also known as polyglycaprone. It's a copolymer of glycolide plus caprolactone. And you know, this monocryl, it is used for subcuticular suturing. This was the question in AIIMS. Used for subcuticular suturing. This is Dexan, and we discussed what's the other name of Dexan. It's also known as polyglycolic acid. Polyglycolic acid. What's the problem with Dexan? That this suture is having highest affinity for adherence to E. coli and Staph aureus. Problem? It's having highest affinity for adherence to two of the most common organisms, E. coli and Staph aureus, and in how many days it is absorbed? It is absorbed in 60 to 90 days. Name of this suture is polydioxanone, and it is also known as PDS. We discussed polyglycolic acid is having highest affinity for adherence to E. coli and Staph aureus. This PDS, it's having lowest affinity. It's having lowest affinity for adherence to E. coli and Staph aureus. This PDS is absorbed in how many days? It is absorbed in 180 days. You have to remember the days. PDS is absorbed in 180 days. Here you can see this blue colored suture, and that is proline. It's a monofilament suture. What kind of suture? Absorbable or non-absorbable? So this is monofilament. It's non-absorbable suture, and you have seen in general surgery where we are using the proline. You have seen in abdominal closure for rectus sheath. Second use, it is used in vascular anastomosis. So what are the uses? We use it for rectus sheath, and the second very important use, it is used in vascular anastomosis, right? These are the commonly used sutures which are frequently asked in exams. So let's quickly revise which suture is absorbed in how many days. So in 60 days we discussed which suture is absorbed. It's catgut. Catgut. 60 to 90 days, there are 3 sutures which are absorbed in 60 to 90 days, and the sutures are Vicryl, chromic catgut, Dexan. How to remember? VCD. VCD is absorbed in 60 to 90 days, Vicryl, chromic catgut, and Dexan. In 90 to 120 days, it's monocryl. And what's the other name of monocryl? It's polyglycaprone. And we discussed in 180 days which suture is absorbed? PDS, also known as polydioxanone. Now see the questions related to uses of sutures. Silk, you have seen in surgery OT, we are using silk for closure of skin. So this is used for skin closure. We discussed Vicryl is delayed absorbable suture used for the organs where there is increased risk of stone forming tendency. So the mnemonic was CUB, C-U-B, right? So it was CBD, U means ureter, and B means bladder, right? Proline, it's a non-absorbable suture, monofilament. This is used for rectus sheath. Rectus sheath. Apart from rectus sheath, it is also used for vascular anastomosis. So what's the other use? It's used for vascular anastomosis, right? And what's the use of nylon? This was asked in a state entrance exam once. Nylon sutures are used for repair of tendon. So nylon is used for tendon. These are the questions related to uses of sutures. Now see the question, if the length of wound is x, what should be the length of suture required? It is 4x. And what's the name of this rule? This is Jenkins rule. What is this Jenkins rule? Suture length to wound length ratio should be 4:1. What? Suture length to wound length ratio should be 4:1. Second question, if we are going to perform the suturing of elliptical incision, what should be the ratio between length and width of incision? So this is the elliptical incision, and here you can see this width is x. We want that the incision should heal without any tension. So what should be the ratio of length to width? So in elliptical incision, the length to width ratio should be 3:1. And third important principle, imagine the skin thickness is x. When you are going for suturing, the skin thickness is x. So what should be the distance between the suture? It is double of the skin thickness. So ratio of distance between suture to the skin thickness, it's 2:1. So three principles you have to remember. Jenkins rule, suture length to wound length ratio 4:1. In elliptical incision, we want the incision to heal without tension. Length to width ratio 3:1. So ratio of distance between sutures and skin thickness should be 2:1. So 4:1, 3:1, 2:1, you have to remember. Nowadays, image-based questions are asked related to knots. How to crack these questions is very easy. First, see square knot and granny's knot. How to differentiate? Square knot is also known as reef knot. It's a stable and secured knot. Granny's knot is also known as pseudo square knot. It's not a stable knot. In both, what are the similarities? How many throws? This is first throw, this is second throw. Here also first throw, second throw. In each throw, how many wraps? So in each throw you can see there is one wrap. Two throws, single wrap in each throw. These are the similarities. What's the difference? That in square knot, crossing occurs in each throw. Crossing occurs in each throw, and in granny's knot, crossing doesn't occur. Right? How to differentiate it on the basis of image? It's very easy to differentiate. If you see square knot, the both ends are together. So here you can see this red color ends are above blue color, and on the opposite side you can see the blue color ends are below the red color. So both ends are together like this. And if you see granny's knot, here one end is below blue and one end is above blue. So here it's like this. Ends are not together in granny's knot and ends are together in square knot or reef knot. Clear? It is very easy to differentiate surgeon's knot. Why? Because in first throw there are two wraps. Can you see here? This is first wrap and this is the second wrap. So in first throw there are two wraps, and in the second throw there is one wrap. Crossing occurs in each throw. So this is surgeon's knot. So you can easily differentiate it on the basis of images. Surgeon's knot, how to differentiate? There are two wraps in the first throw. Now see important questions related to suturing techniques. First, simple interrupted suture. So here you can see the needle is going to pierce the skin at right angle. This was asked in a latest exam. So needle is going to pierce the skin at right angle or 90 degree. It is going to traverse both edges and then exit again at 90 degree. So it comes out at right angle. So this is what? Simple interrupted suture. If we go for eversion or inversion of wound edges, if you want eversion or inversion of wound edges, generally we go for mattress sutures. You have seen that some wounds are not having even edges. If it's not even, so what, for better approximation of wound edges, we go for mattress sutures. Mattress sutures are of two types: vertical mattress and horizontal mattress. How to differentiate? Have a look. So this is horizontal mattress, and this is vertical mattress. Okay, how to differentiate? Have a look. The initial suture is like simple interrupted suture. The skin is pierced at right angle, both edges are traversed. But what? After that, you can see the needle moves horizontally. So after initial suture has interrupted, needle moves horizontally in horizontal mattress and needle moves vertically in vertical mattress. How to differentiate? On the basis of image only. Imagine that this is the incision, line of incision. This is the line of incision. In horizontal mattress, the suture is parallel to line of incision, and in vertical mattress, it's perpendicular to the line of incision. So here you can see it is perpendicular, right? So this is horizontal mattress, this is vertical mattress. You have seen in surgery, in herniatomy and appendectomy, we are using purse string suture. So this purse string suture is generally used for a circular wound. How it's applied? Here you can see the suture is parallel to the edges of a circular wound. So generally what's the use in surgery? We discussed that it is used in appendectomy. This is purse string suture. It is used in appendectomy and in hernia surgery. In hernia surgery, generally for the sac. So what's the name of this suture? It's purse string suture. This is purse string suture. In relation to bowel anastomosis, there are two questions which are asked. First, whenever we are going for bowel anastomosis, the edges should be inverted. It should not be everted because there is increased risk of leak. So edges should be inverted. Inverted edges in bowel anastomosis. Okay, first. Second, which kind of anastomosis is preferred in bowel is the single layer. Can you see? Single layer extramucosal. So for bowel anastomosis, it's single layer extramucosal anastomosis. It is preferred. Single layer extramucosal anastomosis is preferred, and in bowel anastomosis the edges should be inverted. So this is all about sutures and anastomosis. Now we are going to discuss nutrition. So you know that adjuvant nutritional support can be provided by enteral nutrition or by parenteral nutrition. What is enteral nutrition? In enteral nutrition, the nutrients are directly delivered into GIT, enteral. And in parenteral nutrition, the nutrients are given by IV route. So see the various routes of enteral and parenteral nutrition. So the adjuvant nutritional support can be enteral, it's enteral nutrition, and the second is parenteral nutrition. That's parenteral. Okay, so in enteral nutrition, nutrients are directly delivered into GIT. What are the routes of enteral nutrition? It can be given by nasogastric tube, it can be given by nasojejunal tube, it can be given by gastrostomy tube or jejunostomy tube. These are the routes. Out of these routes, see, if we compare nasogastric tube and nasojejunal tube, which one is preferred? In the nasogastric tube, the nutrients are directly delivered into stomach, and because of that there is gastric distension of fullness and it is having high risk of aspiration. That's why it's the nasojejunal tube which is preferred over nasogastric tube. So what's the advantage? In comparison to nasogastric tube, there is no risk of aspiration. So nasojejunal tube is preferred. Second, we are going to compare gastrostomy and jejunostomy tube. So same region, that in gastrostomy tube, you put nutrients into stomach directly, there is gastric distension and again there is increased risk of aspiration. Second, the jejunostomy tube, if we give nutrients via jejunostomy tube, it's better tolerated. So this jejunostomy tube, it's preferred over gastrostomy tube. So jejunal tube, nasojejunal tube preferred over nasogastric tube, jejunostomy preferred over gastrostomy. Parenteral nutrition, where the nutrients are directly delivered via IV route, it is of two types: peripheral parenteral nutrition, in which the nutrients are given into a peripheral vein, and total parenteral nutrition. Here the nutrients are given via a central vein. PPN, it's given for short duration. So whenever the requirement is for short duration up to 2 weeks, we can go for PPN, but the preferred form of parenteral nutrition is what? TPN, and it is also known as total parenteral nutrition. Now coming to the vein, which vein is preferred for total parenteral nutrition? In central vein, the preferred vein is the subclavian vein, followed by internal jugular vein, followed by femoral vein. So what is the preferred vein for total parenteral nutrition? Subclavian vein, followed by internal jugular vein, followed by femoral vein. Sometimes you get a twist in the question that in trauma patients, because of easy accessibility and lesser time required, the preferred vein for TPN is internal jugular vein. So if in the question it's specifically mentioned which vein is preferred in trauma, then it's internal jugular vein, and if nothing is mentioned which central vein is preferred for TPN, it's subclavian vein followed by internal jugular vein followed by femoral vein. There are two questions which are frequently asked in relation to central venous catheterization. That what is the most common complication of central venous catheterization, and this is catheter related sepsis. And what is the most dangerous complication? You might have seen in the ICUs, whenever the anesthetist is inserting the central line into subclavian vein, there is injury to apex of lung and it can lead to pneumothorax. So two questions: most common complication of central venous catheterization, and that is catheter related sepsis. It's catheter related sepsis. Okay, and what's the most dangerous complication? Pneumothorax. You have to remember, it's pneumothorax. There is another complication which is asked frequently, that's refeeding syndrome. So the patients who are having severe chronic malnutrition, and whenever you are going to start rapid and excessive feeding, there are constellation of symptoms. Constellation of symptoms because of rapid and excessive feeding. So the term is self-explanatory. It is refeeding syndrome. Which patients? The patients who are having severe and chronic malnutrition. And in these patients, if we start rapid and excessive feeding, what's the problem? There is shift of metabolism. So initially in malnutrition, what is the substrate? It's fat. And when you start the rapid and excessive feeding, there is shift in metabolism of substrate from fat to carbohydrate. And whenever the substrate is going to change, what happens? There is increased release of insulin. And because of this increased release of insulin, there is rapid uptake of electrolytes by cells. So migration of electrolytes occurs into the cells. Which electrolytes are migrated mainly? Have a look. So because of this increased insulin, the phosphate is migrated, leading to hypophosphatemia. Magnesium is migrated, leading to hypomagnesemia. There is uptake of potassium, so there is hypokalemia, and uptake of calcium, hypocalcemia. So this kind of dyselectrolytemia seen in the patients of refeeding syndrome. So because of these dyselectrolytemias, the patients are prone to develop what? Arrhythmias. There can be arrhythmias. There can be confusion and respiratory failure. And all these, if not corrected on time, can lead to death. right? So this is going to happen in refeeding syndrome. Refeeding syndrome is only seen with enteral nutrition, only seen with total parental nutrition, or it is seen with both. It is seen in both total parental nutrition as well as enteral nutrition, seen in both. So which one is having increased risk? It's the total parental nutrition which is having increased risk over enteral nutrition. So this is all about nutrition. Now we are going to discuss shock. So what is shock? It's the clinical syndrome resulting from inadequate tissue perfusion. And in the clinical scenarios or clinical settings, you have seen what's the most common type of shock? It's hypovolemic shock. So overall, the most common type of shock is the hypovolemic shock. Okay, what's the cause? It's because of loss of blood volume, loss of plasma volume, body sodium or water. You have seen both in medicine and surgery. There are two one-liner questions which are asked in relation to shock, that what's the best clinical indicator of tissue perfusion in shock patients, and this is what urine output. Best clinical indicator for tissue perfusion in shock patients, that's urine output. And if the question is asked what's the best indicator to detect fluid required for resuscitation, and that is central venous pressure, CVP. In relation to urine output, you know, if there is adequate tissue perfusion, how much should be the minimum urine output in adults, and in adults it's 1 ml per minute. How much? In adults it's 1 ml per minute, and in children it's 0.5 to 1 ml per minute, right? So you can calculate it in per hour. In adults it is 60 ml per hour, and in children the range is 30 to 60 ml per hour. One of the commonly asked question in relation to shock is ATLS classification of hypovolemic shock. So according to ATLS classification, there are 4 classes of hypovolemic shock depending on the amount of blood loss. So how much is the blood loss? In class 1, it's 0 to 15%. How much is the loss in class 2? 15 to 30%. Class 3, it is 30 to 40%, and in class 4, it is 40%. So how to remember? Just remember this digit. It is 3, 30, 4, 40. 3, 30, 4, 40. Okay. And 1 and 2, 1 is 0 to 15 and 2 is 15 to 30. Now see the pulse rate. If we see class 1 here, the pulse rate is less than 100 per minute. In class 2, it's more than 100. In class 3, it's more than 120. And in class 4, it's more than 140. So here, more than 120 and more than 140. Coming to the blood pressure. Blood pressure is maintained in class 1 and class 2. It is maintained, but BP is decreased in class 3 and class 4. How blood pressure is maintained? Because of sympathetic stimulation, there is vasoconstriction and there is tachycardia. So BP is maintained in class 1 and class 2 because of sympathetic stimulation. If we see the urine output in class 1, it's more than 30 ml per hour. In class 2, it is 20 to 30 ml per hour. Class 3, 5 to 15 ml per hour. And in class 4, it's almost nil or negligible. Which fluid should be used for resuscitation? Hypovolemia or hypovolemic shock, it's because of blood loss, loss of plasma volume, loss of sodium or water. So in class 1 and class 2, we give crystalloids. Crystalloids are used in class 1 and class 2. But in class 3 and class 4, apart from crystalloids, we give blood transfusion also. So blood transfusion is also given in class 3 and class 4. So this is very, very important. What you have to remember mainly, how much is the blood loss? Class 1, 0 to 15, class 2, 15 to 30, 3, 30 to 40, and 4 more than 40%. See the important questions related to physiological characteristics of various types of shock. These are frequently asked questions. Firstly, hypovolemic shock. So there is loss of blood volume, plasma volume, body sodium and water. What happens in hypovolemic shock? There is sympathetic stimulation that leads to tachycardia and vasoconstriction. So here the parameters are CVP, central venous pressure, PCWP, that is pulmonary capillary wedge pressure, CO, that is cardiac output, SVR, systemic vascular resistance. So in hypovolemic shock, what happens? There is decreased central venous pressure and PCWP. Cardiac output is also decreased. Because of vasoconstriction, systemic vascular resistance is increased. And if we see venous oxygen saturation, in all types of shock, venous oxygen saturation is decreased except hyperdynamic phase of septic shock. Okay. Coming to the cardiogenic shock. So in cardiogenic shock, there is increased central venous pressure and pulmonary capillary wedge pressure. Obviously, there will be decreased cardiac output, increased systemic vascular resistance and decreased venous oxygen saturation in cardiogenic shock. Septic shock is further divided into hyperdynamic phase and hypodynamic phase. What happens in hyperdynamic phase, you have to remember, is very, very important. Here, the central venous pressure and pulmonary capillary wedge pressure, it can be decreased also, it can be increased also. But cardiac output is increased in hyperdynamic phase of septic shock. It's the only type of shock where cardiac output is increased. If we see systemic vascular resistance, it is decreased and venous oxygen saturation is also increased. You have to remember, hyperdynamic phase of septic shock is the only type of shock in which cardiac output is increased and venous oxygen saturation is increased. In hypodynamic phase, if we see central venous pressure, pulmonary capillary wedge pressure, it can be decreased also, increased also. Cardiac output is decreased and here systemic vascular resistance is increased and obviously venous oxygen saturation, it can be decreased also, it can be increased also. Okay. Neurogenic shock. What's the problem in neurogenic shock? There is loss of sympathetic tone, and because of this loss of sympathetic tone, there is vasodilatation in both arteries and veins. And if there is vasodilatation in both arteries and veins, what happens? There is decreased CVP and pulmonary capillary wedge pressure. Obviously, there is decreased cardiac output, there is decreased systemic vascular resistance and decreased venous oxygen saturation. So if you see, this is the only type of shock where all parameters are decreased. Which shock? Neurogenic shock. All parameters are decreased in neurogenic shock. If you see hypoadrenal shock, in this there is decreased CVP and pulmonary capillary wedge pressure, decreased cardiac output. Systemic vascular resistance can be normal also or it can be decreased also. And venous oxygen saturation, it is decreased. So see the important questions which are asked here. What? Systemic vascular resistance is increased in hypovolemic shock. Here you can see in cardiogenic shock, CVP and pulmonary capillary wedge pressure is increased. Hyperdynamic phase of septic shock is the only type of shock in which there is increased cardiac output and increased venous oxygen saturation, and all parameters are decreased in which type of shock? Neurogenic shock. There is a famous question which is asked in relation to trauma and shock. See the scenario. The question is asked that road traffic accident patient was brought to your emergency. At the time of presentation, patient is having tachycardia and what? There is cold peripheries. So what's the cause? Which type of shock? So it is because of hypovolemic shock. Because in hypovolemic shock, in trauma patients, there is loss of blood volume. Sympathetic stimulation is there. So patient is having tachycardia, and because of vasoconstriction, there are cold peripheries. Second situation, sometimes in trauma patients, there is neurogenic shock, and because of this neurogenic shock, there is loss of sympathetic tone. If there is loss of sympathetic tone, what will happen? There is bradycardia and there is vasodilatation in arteries and veins leading to warm peripheries. So whenever there is tachycardia and cold peripheries, it is seen in hypovolemic shock. This is seen in hypovolemic shock. And if there is bradycardia and warm peripheries, it is seen in neurogenic shock. This is seen in neurogenic shock. So these are the important questions related to physiological parameters and clinical manifestations of shock. There are two parameters which are asked. One is shock index and the second is modified shock index. What is the formula of shock index? It is heart rate divided by systolic blood pressure. And what is the formula of modified shock index? This is heart rate divided by mean arterial pressure. Shock index is also known as hemodynamic stability indicator. Also known as hemodynamic stability indicator. This modified, if you are going to compare shock index and modified shock index for mortality rate prediction, MRP, for mortality rate prediction, which one is the better marker? So it's the modified shock index. It's the better marker for mortality rate prediction in comparison to shock index. So you have to remember the formula. Shock index is heart rate divided by systolic blood pressure. Modified shock index, heart rate divided by mean arterial pressure. So these are the important points related to shock. Now we are going to discuss important topics of general surgery. First, we are going to discuss hospital acquired infection. In one of the latest exam, definition of hospital acquired infection was asked. So what's the definition? Whenever any infection occurs within 48 hours of hospital admission or within 3 days of discharge or within 30 days of an operation. So how to remember? 2, 3, 30. 2 days or 48 hours of hospital admission, 3 days of discharge or 30 days of surgery, that is hospital acquired infection. You must be knowing what is the most common type of hospital acquired infection. It's urinary tract infection. And what is the most common type of hospital acquired infection in surgical patient? Obviously that's surgical site infection. So see the types of hospital acquired infection. Overall, most common is urinary tract infection. The second most common is surgical site infection. Third is respiratory infection. Fourth is bacteremia. And fifth is antibiotic associated diarrhea. So if we see the incidence, according to incidence, most common is UTI followed by surgical site infection, followed by respiratory infection, followed by bacteremia, followed by antibiotic associated diarrhea. Okay, how to remember? The mnemonic is USSR ban. So how to remember? The mnemonic is USSR ban. Okay, UTI, S surgical site infection, R respiratory tract infection, B bacteremia, and AN, that is antibiotic associated diarrhea. We discussed overall most common is UTI, and surgical site infection, it's most common hospital acquired infection in surgical patient. Simple. Now see the question. For UTI, urinary tract infection, what's the most common organism responsible? And that is E. coli. Let me tell you, for most of the infection in surgical patients, most common organism responsible is E. coli. So see how E. coli is responsible for most of the surgical infections. So we discussed most common hospital acquired infection is UTI, and what's the most common organism responsible, and that is E. coli. So here you can see E. coli is responsible for urinary tract infection. Via urinary tract or via urethra, this E. coli is reaching where? Prostate. And if it reaches prostate, it can cause acute bacterial prostatitis, chronic bacterial prostatitis, and prostatic abscess. So for all these conditions, what's the most common organism responsible? E. coli. So acute bacterial prostatitis, chronic bacterial prostatitis and prostatic abscess. Prostatic abscess. In all these cases, most common organism responsible is E. coli. Now see what happens via epididymis. Via epididymis, the organism reaches to epididymis and sometimes it can involve the testis. So if epididymis is involved, that is epididymitis. If testis is involved, that's orchitis, and when both are involved, that's epididymoarchitis. So you must be knowing acute epididymoarchitis. Acute epididymoarchitis in children, in elderly, and in homosexuals. In children, elderly, and homosexuals. In all these cases, what's the most common organism responsible? E. coli. Okay. Another problem, certain patients are having vesico-ureteric reflux. So via urine, can you see the bacteria reaches where? To the kidney. When the patient is having vesico-ureteric reflux, organism reaches kidney, it can lead to what? Pyelonephritis. So if there is acute pyelonephritis, chronic pyelonephritis, emphysematous pyelonephritis, and sometimes there is perinephric abscess. In all these cases, what's the most common organism responsible? That's E. coli. Clear? So here you can see for infections related to prostate, for infections related to epididymis, testis, acute epididymoarchitis, and infections related to kidney, what's the most common organism responsible? That is E. coli. Now let's see the conditions of hepatobiliary pancreatic tract and GIT where E. coli is the most common organism responsible for the infections. So in cases of cholangitis, pyogenic liver abscess, spontaneous bacterial peritonitis in adults, infection in pancreatic necrosis, and in anorectal abscess. In all these cases, what's the most common organism responsible? That's E. coli. Right? So it's very, very important. It's very easy to remember. In majority of cases, what you saw, that the most common organism responsible is E. coli. For the last 3-4 years, you have seen in majority of exams, they are asking the scoring system for severity of wound infection. One is Southampton wound grading system and the second is asepsis wound score. So one by one we are going to discuss. First, Southampton wound grading system. So total there are 6 grades from 0 to 5, and how to remember, the mnemonic is NBE-CPD. First, how to remember it? NBE-CPD. N means grade 0 is normal healing of wound, and whenever there is bruising or erythema, normal healing with mild bruising or erythema, it is grade 1. In grade 2, there is erythema plus other signs of inflammation, and in grade 4, it's C, that is clear or hemoserous discharge. In grade 4, there is pus collection, and if there is deep wound infection with or without tissue breakdown, that is grade 5. So what's NBE-CPD? Normal healing. B means bruising, E means erythema with other signs of inflammation, C clear or hemoserous discharge, P pus collection, D that deep wound infection. So this is how you remember 0 to 5 grades. After that, sometimes they are asking questions related to subtypes and appearances. Okay, so see, the grade 1 is further divided into grade 1A, 1B, 1C. So what happens? In 1A, there is bruising, so there is some bruising. In 1A, there is some bruising. In grade 1B, there is considerable bruising. Clear? And in grade 1C, there is mild erythema. Mild erythema. Clear? Now grade 2 is further divided into A, B, C, D, E. What is grade 2A? Here, there is erythema plus other signs of inflammation in 2A at one point. If it's at one point. In 2B, it's around the sutures. Around sutures. And in 2C, it's along the wound. Along the wound. and in 2D it's around the wound. So 2D, that's around the wound. 3, that is clear or hemoserous discharge, is further divided into 3A to 3D, A, B, C, D, E. So see, what is 3A? Here, there is clear or hemoserous discharge at one point only. At one point only. Okay, it means less than 2 centimeter. If it's along the wound or more than 2 centimeter, this is 3B. What happens in 3C? There is large volume. There is large volume of discharge. Whenever the discharge is prolonged for more than 3 days, it is 3D. So in 3D, it's prolonged, and this is for more than 3 days. Clear? Grade 4 is also further divided into grade 4A, 4B. In 4A, whenever the pus collection is at 1 point or less than 2 centimeter, at 1 point or less than 2 centimeter, and whenever it's along the wound or more than 2 centimeter, that is 4B. And what is grade 5? It's deep wound infection with or without tissue breakdown. You have to remember Southampton wound grading system because it's very, very important. Every year there is one question from this grading system. And the mnemonic is NBE CPD. Another wound scoring system which is asked, and that is asepsis wound score. A means additional treatment. So what kind of additional treatment? Yes, we give antibiotics for wound infection. Antibiotics. If there is pus collection, what? We have to drain. So drainage of pus under local anesthesia. And whenever there is infection or necrosis, we go for debridement. And this debridement is done under general anesthesia. So additional treatment, antibiotics for infection, drainage of pus under local anesthesia, debridement under general anesthesia. That's A. S means serous discharge, E means erythema, P means purulent exudate, S, that is separation of deep tissues, I, that is isolation of bacteria from wound, and S, that is stay as inpatient, and this stay is prolonged for more than 14 days. Okay, so prolonged stay as inpatient. So here you can see the mnemonic is hidden in this word asepsis. Additional treatment, A, serous discharge, E, erythema, P, purulent exudate, S, separation of deep tissues, I, isolation of bacteria from the wound, and S, stay as inpatient. It's prolonged, and what's the duration? More than 14 days. So you have to remember asepsis wound score. In this image you can see that there is infected mass filled with dead tissues and pus. And you can notice that there are multiple openings into the skin and pus is draining through that openings. So what is this? This is carbuncle, and you know that carbuncle is commonly seen in the patients who are having diabetes or in immunocompromised patients. What's the most common site of carbuncle? It's the nape of neck. So the first question, what's the most common organism responsible for carbuncle? It's Staph aureus. Okay, and what's the most common site? It's the nape of neck. Nape of neck. You will notice for majority of infections, there are two predisposing factors. One is diabetes mellitus and second is immunocompromised state. So these are also the risk factors for what? Carbuncle. How we are going to manage these patients? So since there is abscess, there is infected mass, so you have to perform incision and you have to perform the drainage. Incision and drainage with antibiotics. What kind of incision is given? We have to give cruciate shaped incision. So here you can see this is cruciate shaped incision. So the treatment is incision and drainage plus antibiotics, and we give cruciate shaped incision. We discussed that this cruciate shaped incision is given in other place in surgery where we were using this in anorectal abscess, right? So for carbuncle as well as for anorectal abscess, we are using cruciate shaped incision to drain the pus. In this image, here you can see that there is brown exudate. What's the color of this exudate? Brown exudate. And you can see that there is spreading infection. You can see that brownish, blackish discoloration. There is spreading infection. So brown exudate, spreading infection, these are characteristic features of what? Gas gangrene. In gas gangrene, there are two terms. Gas, there is gas plus there is gangrene. So you are going to notice that there is blackish or brownish discoloration with presence of gas. Whenever there is presence of gas and we are going to perform the palpation, because of this gas, there is crepitus. It's crepitus because of the gas. Now there is another condition which looks like gas gangrene superficially, and that's necrotizing fasciitis. How to differentiate? In necrotizing fasciitis, there is necrosis up to the deep fascia. So there is involvement of skin, superficial fascia, deep fascia. What happens in gas gangrene? There is myonecrosis also. What? There is myonecrosis or muscle necrosis, and this feature differentiates it from necrotizing fasciitis. The name is gas gangrene. It means it is caused by a gas producing organism. That's anaerobe. And what's that organism? It's the Clostridium perfringens. So question, most common organism responsible, and that's Clostridium perfringens. It's the Clostridium perfringens. Okay. Here in gas gangrene, gas and smell are characteristic features. What? Gas and smell. These are the characteristic features. We discussed that there are two risk factors for most of the wound infections. One is diabetes mellitus and the second is immunocompromised state. Right? So obviously these are the risk factors for gas gangrene also. But Clostridium perfringens is an anaerobe, so it requires anaerobic condition. So any traumatic wound which is having extensive wound contamination, or there is presence of necrotic or foreign material which is going to promote the anaerobic condition, that's also a risk. So contaminated wound containing foreign material or necrotic material which promotes the anaerobic condition, it can lead to gas gangrene. How we are going to treat gas gangrene? We have to give large doses of IV penicillin, plus extensive debridement of the wound. We go for extensive debridement of the wound. Whenever some patient of trauma who is having extensive contamination or there is presence of necrotic material, these patients are coming to us, we have to go for prophylaxis of gas gangrene. So what's the prophylaxis of gas gangrene? So patients who are at risk, in those patients we have to start antibiotics. We give passive anti-gas gangrene serum. Generally it's given IM, intramuscular, but in cases of emergency we can give it IV also. Generally it is given IM. We have to delay the closure of traumatic wound for how many days? At least for 5 to 6 days. So delay the closure of traumatic wound for 5 to 6 days. So this is the prophylaxis for gas gangrene, and we follow this in patients who are having the risk of gas gangrene. In this image, you can see that there is blackish discoloration of the limb. Simultaneously, you can notice there is erythema and edema also. So three findings: blackish discoloration, erythema, edema, and if we do the palpation, there is woody hard texture. So what is this? It is necrotizing fasciitis. This is necrotizing fasciitis, and this is rapidly spreading bacterial infection. So what's the most common site? Here you can see it's the lower limb. Okay, it's a bacterial infection. What kind of bacterial infection? It's polymicrobial infection. It's caused by both aerobes and anaerobes. So it's polymicrobial, caused by both aerobes as well as anaerobes. If a question is asked that single most common organism responsible for necrotizing fasciitis, and that's group A, beta hemolytic streptococci. Is the group A beta hemolytic streptococci. Okay, term is self-explanatory. There is necrotizing fasciitis, so there is necrosis of the structure, still deep fascia, skin, subcutaneous tissue, superficial fascia, deep fascia. Underlying structures are spared. It means muscle is spared. We discussed gas gangrene. In gas gangrene, there is myonecrosis. So muscle is involved in gas gangrene, but it is spared in necrotizing fasciitis. Whenever these patients are coming to us, they have severe pain in the limb or at the site of necrotizing fasciitis. There is severe pain. Sometimes even without treatment, the pain disappears. And if pain disappears without the treatment, it's an ominous sign. Why? Because there is thrombosis of vessels. So if there is thrombosis of vessels and there is destruction of nerves, because of that pain disappears. So if pain disappears without treatment, it's an ominous sign. We discussed the wound is edematous, and what? There is woody texture. These patients have 100% mortality if surgical debridement is not done. So what we have to give? In all patients, you have to give IV fluids, you have to give IV antibiotics, and you have to go for extensive surgical debridement. What we have to go for? Extensive surgical debridement in patients who are having necrotizing fasciitis. Otherwise, there is 100% mortality without surgical debridement. What are the other names of chronic burrowing ulcer? It is also known as Melanese gangrene, also known as burrowing phasdenic ulcer, also known as progressive synergistic gangrene. Why it is known as progressive synergistic gangrene? Because it is caused by synergistic infection. What are the two organisms whose synergistic infection is responsible for chronic burrowing ulcer? So it's the synergistic infection of microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Okay, it's because of synergistic infection of these two organisms. Now see, the term is self-explanatory. It is chronic burrowing ulcer. So there is burrowing cutaneous fissures and sinus tracts. So there is burrowing cutaneous fissures and there is presence of sinus tract. And what is the important property? That these fissures and sinus tracts, these are going to open at the distal sites. So both of these are going to open at distal sites. Clear? So this is chronic burrowing ulcer, also known as Melanese gangrene. This is tuberculous lymphadenitis, and tuberculous lymphadenitis is asked both in pediatrics as well as in surgery. See the age group. It is more common in children and young adults. And what is the most commonly involved lymph node? It's the deep cervical lymph nodes. How? Mycobacterium tuberculosis goes to the deep cervical lymph node. So organism enters through the tonsil, and via tonsil it reaches deep cervical lymph nodes. So what happens in this tuberculous lymphadenitis? Okay, initially you can see there is inflammation of these lymph nodes. After that, what happens? There is periadenitis, and the lymph nodes are moving together en masse. And when the lymph nodes are moving together en masse, this is known as matting. So in lymphadenitis stage also, what? It's non-tender, firm to hard lymph node, and in matting also, it's non-tender, firm and hard. After that, what happens? There is liquidation and breakdown. Because of this liquidation and breakdown, there is formation of cold abscess. So here, this cold abscess is collected beneath deep fascia. You can see this is the deep fascia and this is the superficial fascia. So the cold abscess is located beneath deep fascia. What happens? At one point of this cold abscess, there is rupture. So if rupture occurs at one point, what happens? Now the pus flows and it is collected into the space which is located beneath superficial fascia, and this is known as what? Collar stud abscess. Okay. In collar stud abscess, generally the pus is adherent to the skin. In certain cases, it's going to rupture outside, and if it ruptures outside, what? There is formation of sinus. What kind of sinus is there in tuberculosis? If you have seen, so in this image you can see this kind of sinus. This sinus is having undermined edges. What? Sinus with undermined edges, typical of tuberculosis. Clear? So these are the important points related to tubercular lymphadenitis. How to treat? Since it is caused by Mycobacterium tuberculosis, we have to start the ATT. In certain cases, even after ATT, what? The abscess is not going to resolve, and if abscess is not going to resolve, in that case we have to go for excision, and in that excision we have to remove the abscess cavity, we have to remove the lymph nodes as well as fibrous capsule. So there should be excision of cavity, lymph nodes and fibrous capsule if it's not going to improve after ATT. See the important questions related to typhoid or enteric fever. What's the most common organism? It's Salmonella typhi or paratyphi. Salmonella typhi or paratyphi. Second question in relation to enteric fever, that what's the most common cause of ileal perforation in tropical countries like India? The most common cause of ileal perforation in tropical countries like India, yes, it's enteric fever. What's the problem? See the pathophysiology. In enteric fever, there is ulceration and necrosis of ileocecal Pierce patches, and there is formation of longitudinal ulcers in the ileum. So in the image you can see here, there is presence of transverse ulcers. Can you see? These are the transverse ulcers, and these are seen in tuberculosis. And if you see this longitudinal ulcer, these longitudinal ulcers are seen in what? Typhoid. Clear? So transverse ulcers in tuberculosis, longitudinal in typhoid, and it's because of necrosis and ulceration of what? Pierce patches of IC, ileocecal area. Coming to the clinical features, the patients who are having typhoid, they have high grade fever and there is abdominal pain. So fever and abdominal pain, these are hallmark symptoms. Hallmark symptoms. What's the most common complication? So in patients of enteric fever, there is paralytic ileus. That's the most common complication, followed by intestinal hemorrhage. So complication is the paralytic ileus. This is the most common complication, followed by intestinal hemorrhage. And one question which is frequently asked, that perforation occurs. What's the site of perforation? Ileum. So in which week perforation is going to occur? Perforation occurs in third week. Perforation occurs in third week of enteric fever. The characteristic signs which are seen in patients of enteric fever or typhoid, there are rose spots. We have to palpate the abdomen. There is splenomegaly. In these patients, generally in bacterial infection, there is leukocytosis. There is leukopenia with shift to left, and there is high grade fever in patients of typhoid, but what? There is relative bradycardia. So on investigations, you are going to find leukopenia and the pulse rate is not high in comparison to the fever. So that's relative bradycardia. These are highly suggestive of enteric fever. SIRS is also frequently asked in exam, full form systemic inflammatory response syndrome. So it's the body's inflammatory response to infectious or non-infectious insult. What are the mediators for SIRS? IL-1, IL-6 and TNF-alpha. These are the mediators. There are 4 components or 4 parameters of SIRS. Out of 4, if 2 or more than 2 are present, it means it's there. So the 4 parameters are temperature, heart rate, respiratory rate, WBC count. Temperature, it's either more than 38 degrees centigrade or less than 36 degrees centigrade. Heart rate, when it's more than 90 per minute. Respiratory rate, when it's more than 20 per minute. WBC count, when it's more than 12,000 per microliter or less than 4000, or there is more than 10% of immature cells in the peripheral smear. So out of these four, if 2 or more than 2 are positive, it means SIRS is positive. There is systemic inflammatory response syndrome. How to remember? The mnemonic is THR counts. Mnemonic THR counts. So T temperature, H heart rate, R respiratory rate, count it means WBC count. It's very important, frequently asked one-liner, so you have to remember. Three other definitions are asked. What is sepsis? What is severe sepsis? And what is septic shock? So whenever patient is having systemic inflammatory response syndrome plus established focus of infection, there is established focus of infection, right? And that is sepsis. Okay. Whenever there is sepsis plus organ dysfunction and hypoperfusion, it is severe sepsis. So sepsis plus organ dysfunction and hypoperfusion, that is severe sepsis. Okay. And what is septic shock? When the patient is having severe sepsis not responding to IV fluids. So severe sepsis which is not responding to IV fluids, that is septic shock. Okay. There is another definition which is asked, multi-organ dysfunction syndrome, modes. So this multi-organ dysfunction syndrome is self-explanatory. Multi-organ means here 2 or more than 2 organs are involved. So how many organs? There are 2 or more than 2 organs. And what's the problem in these organs? There is dysfunction. So what kind of dysfunction? There is physiologic dysfunction. What? Physiologic dysfunction and or organ failure. So physiologic dysfunction and or organ failure in 2 or more than 2 organs, and that's known as MODS, multi-organ dysfunction syndrome. What's the most important factor in prevention of wound infection? And it's the hand washing. So we should wash our hands in between 2 patients. Right? Hand washing, this was asked many times in AIIMS, is the most important factor in prevention of wound infection. Second, whenever we take the patient for surgery, generally we go for part preparation. It means hair removal prior to surgery. So which method is having least risk of infection? And that is on-table clipping. On-table clipping, it's having least risk of infection. Which method is having maximum risk of infection? If you go for preoperative shaving. Because of preoperative shaving, there are multiple cuts in the skin and which promotes the growth of bacteria. So best method is on-table clipping. And which method is having maximum infection rate? Preoperative shaving. Use of prophylactic antibiotics. Question which was asked many times, that at which particular time you have to give the prophylactic antibiotics? It's given at the time of induction. It's given at the time of induction. Suppose induction is not mentioned in the question, then 30 minutes to 1 hour before surgery, so that antibiotics are there in the circulation when we give the incision. At the time of induction, or it's 30 minutes to 1 hour before surgery. Before surgery. After that, we go for cleaning of part, right? And generally in abdominal surgeries, we have to clean the area from nipple to mid-thigh. So here you can see from nipple to mid-thigh, we are going to clean the area. How we are going to clean? See, the abdomen, we are going to clean from medial to lateral. So here you can see it's clean from medial to lateral. But the perineum is the infected part. So in the perineal region, we go from lateral to medial. In abdomen, from medial to lateral, and in perineal region or in genitalia, area of genitalia, we go from lateral to medial. we have to maintain the ideal OT parameters. So what are the ideal OT parameters which should be maintained? The temperature of OT should be 18 to 25 degrees centigrade. How much should be the relative humidity? It should be 50 to 60%. And the positive pressure should be 2 mmHg above atmospheric pressure. It's 2 mmHg above atmospheric pressure. And how many air exchanges should be there? There should be at least 15 air exchanges per hour. How many? 15. And how many are of fresh air? At least 4 should be of fresh air. So per hour, at least 15 air exchanges, and out of that 15, 4 should be of fresh air. We have to maintain ultra clean laminar flow in the OT. So these are the methods by which we are going to prevent the wound infection. What are the causes of post-operative fever? So if fever occurs within 2 days, means post-operative day 1 or post-operative day 2, it's because of non-infectious cause, and that's atelectasis. So on post-operative day 1 or 2, it's because of atelectasis. On 2nd to 3rd day, fever comes, it's most commonly because of urinary tract infection. On 3rd to 7th day, it's because of surgical site infection, and that's also known as wound infection. On 5th to 7th day, it's because of DVT, or whenever we insert the cannula, there is thrombophlebitis. So it's because of DVT or thrombophlebitis, right? And if the fever is coming after 7 days, it's because of drugs. So that's drug fever. There is a clinical scenario which is frequently asked in exams, especially AIIMS and INI-CT, that after laparotomy, when intern was doing dressing in between 5th to 8th day, the intern noticed that there is serous or serosanguinous or pink color discharge. Serous, serosanguinous or pink color discharge coming from the wound. What's the diagnosis? So serous, serosanguinous or pink color discharge coming from the wound is suggestive of wound dehiscence, and this is also known as Salmon fluid sign. What's the name? Salmon fluid sign when there is serous or serosanguinous discharges coming from the wound. It is wound dehiscence. Typically, this wound dehiscence occurs on 5th to 8th post-operative day. On which day? It's 5th to 8th post-operative day. What are the types of wound dehiscence? It's of 2 types, partial or total. Okay. Imagine a patient is having total dehiscence with extrusion of bowel or viscera, and whenever there is extrusion of bowel or viscera, this is known as evisceration. Management depends whether there is only wound dehiscence or there is extrusion of viscera also. If there is dehiscence only, we have to go for prompt elective closure. Clear? And when the patients are having extrusion of viscera or there is evisceration, first you have to wrap this bowel with moist towel. We have to perform the irrigation with Ringer lactate, which is containing antibiotics, and then we put the bowel back to the peritoneal cavity and we have to close the abdomen. How we are going to close the abdomen? So you can see we are applying tension suturing. So for closure, we go for tension suturing. Clear? So this is how we manage the patients who are having wound dehiscence. So this is all about general surgery.